Okay, welcome everybody to our 14th West Yorkshire Health and Care Partnership Board meeting. As you'll notice, I am not Councillor Tim Swift, I'm Cathy Elliott. I'm Chair of NHS West Yorkshire Integrated Care Board and the new Deputy Chair of our Partnership Board. As many of you know, Councillor Tim Swift has had a planned operation and he's currently recovering. So I am deputising for him today with the support of Councillor Susan Hinchcliffe, and we wished him a speedy recovery. So thank you very much to all of you who've come along today from different places, services and parts of our partnership. This is our 14th meeting as a partnership board, and we've got some fantastic foundations to build on. But this is our first statutory meeting as an integrated care partnership due to the changes that came in place in the 1st of July. And I probably will keep saying this for a while, but thank you to everybody who's been involved in that, particularly colleagues from CCGs moving into NHS West Yorkshire and everyone in the core team and everyone across our partnership who has made this possible to set up the new entity. So today's meeting is aiming to reflect the fact that this is now our partnership board is on a statutory footing. It's aiming to have a strategic focus. You've got an update today, particularly on the process and principles of our strategic refresh, as well as some key policy areas together. We have our report as usual from Health Watch on insights and what people are telling them and us across our health and care services. We will, as our usual, our standing agenda item, hear from our colleagues across the Race Equality Network on the work on tackling health inequalities for Black, Asian and minority ethnic communities and staff. And we will also have a focus at the end of the meeting, and I really want to make sure we get to this part of the meeting and looking at our response to the cost of living crisis and our response as a partnership to poverty issues across our communities. And I will aim for us to have a 5-minute break. You'll see each agenda item is around 15 to 20 minutes or so. Anyone presenting, I know, if you could just give your introductory remarks within a matter of minutes, that would really help us to make sure our colleagues in the partnership can have a discussion and feedback. And I'd also, and it's something Helen Hurst, you've just popped up on my screen, so it made me think of you, how we pinch with pride across our partnership. And I'd really encourage you all today, is as we're talking about certain agenda items, if you've got a new development, a piece of innovation, a pilot, a trial, some new best practice, feel free to put it in the chat box, give us a link to it. This is our job together to help each other raise our practice and improve quality of care for our communities. So be really open with us about things that you feel are working well in your communities and services at the moment to help other colleagues learn from you. So we have got a number of items on the agenda, but I just wanted to reflect a number of things that are taking place. As you know, the Integrated Care Board was set up on the 1st of July under legislative changes, and the Integrated Care Board under NHS West Yorkshire is now meeting regularly. And there's lots of information on the partnership's website under that section. And as you appreciate, there is a lot of guidance coming through from NHS England and gov.uk, including for us for our Integrated Care Partnership on a statutory footing. There's a lot of new people who are moving and joining, particularly as our Director of Corporate Affairs for NHS West Yorkshire, John Ebo moving to West Yorkshire Race Equality Network, and thanking Simon for all the work that she has done over the years and her incredibly valuable input to this board. We also have some new appointments and our non-exec directors for the Integrated Care Board, Aranangsu Chatterjee and also Majid Hussain, who've joined us to complete our non-exec team for NHS West Yorkshire. And we're really pleased that Kim Shuttler is now our new voluntary community and social enterprise representative and also working on HBox for us from the beginning of this month. What that remains then for us is for the Integrated Care Board, the final piece of recruitment is our primary care representative, which we aim to finalise into the next month. The other thing we also want to note is North Yorkshire have gone through a reorganisation in terms of council, but we do remain connected and will be going through for a directed elected mayor soon through their devolution deal. But we will be hearing later about how the governance will relate to that through the terms of reference. So there's a few updates there for you. In Rob's report today, there's a lot of web links there if you want to have further information, particularly on any recent guidance regionally, nationally, or coming through from NHS West Yorkshire. So we'll now move on to the next part of our agenda. Questions and public deputations, we don't have any today, and that doesn't mean that we don't welcome them, and we continue to do both within this forum as our integrated care partnership, as well as within the NHS West Yorkshire Integrated Care Board. And I know through place committees and the work that you're doing within your place partnerships, you continue to welcome input from members of the public, as well as through provider services. So we do have, as always, written responses to all the questions we have in public, and we must encourage others coming forward, particularly for the December meeting and the next integrated, the 20th of September. So that then moves me on to the declarations of interest. Does anyone have any declarations of interest in relation to today's agenda? If you do, either please put your hands up or put it into the chat box so we can note that. I will take silence. There's no declarations of interest there. So that then moves us on to the minutes of the last meeting on the 7th of June, which particularly was our last meeting as a partnership board before the statutory arrangements. Do colleagues feel that's an accurate record of our meeting that day? If you have any comments or typos, please put your hand up or put something in the chat box for my colleagues to pick up on. I will take silence as people are happy with that. In terms of matters arising, we particularly, I'm just picking up on things, we have a number of things on the people plan, which will come back to a future meeting, and we discussed ways of working which are involved in our terms of reference today. We have, thank you for putting the action log up. I think everything is in progress or has been completed. Lauren and colleagues, is there anything that you want to add on the action log?
No, thanks, Kathy. I mean, as you've said, it's all either in progress or has been done. So under the first item, we've got the conversation on poverty later on this agenda. We'll bring something back on the partnership with Sanctuary in 12 months' time. On the green plan, we've deferred that to December just because of the volume of stuff that we want to get through today. We've got the Health Watch Insight report on the agenda today. It's linked to the strategy item, which is helpful, I think, in terms of understanding citizen insight to influence the strategy. And we've got the ongoing item on the response to the race equality review. We've closed the action at the bottom around the people plan. And Kathy, thanks.
That's great. Thank you very much. And something I wanted to add that I've been talking to colleagues about recently, as you appreciate, there's a lot of national guidance, white papers coming through over the last few months or so. And as we look at strategic review and the refresh that Ian's going to talk about later, and our variety of plans, we are working to reference them as well, which I'm sure will come out today. Okay, thank you. So we'll then move on to Rob's update as our West Yorkshire Partnership Chief Exec lead. So Rob, over to you for some highlights. And then colleagues, please let me know if you have any questions or comments by putting your hand up or putting something in the chat box. Rob, over to you.
Thanks, Chair. Hello, everybody. My name's Rob Webster. I'm the Chief Exec of the Integrated Care Board and the lead Chief Exec for the Integrated Care System. It's good to see you all today. And it's good to have a statutory meeting of the Partnership Board, as Kathy said, the 14th meeting of the board itself, and now with legal underpinning following the implementation of the Act. So my paper essentially acts as an update on the context within which we operate, the position we find ourselves in now, what we're doing in terms of planning for the winter, the next 2 years and the next 5, and provides us, I think, with a framing for the rest of the conversation today. As Kathy says, it's good to see that this meeting continues to be held in public. This is the first time, I think, in all the 14 meetings where I've had a public question, but I know that, or several, and I know that the place committees, which also meet in public, have been having good conversations with the public. And it's also worth noting for Partnership Board members that our Quality and Finance Performance Committees also meet in public. So I think this commitment to transparency, openness and clarity is really welcome. He says probably a couple of things to update and a few things I'd like to highlight from my report. Sort of 3 contextual matters to draw people's attention to. I think Kathy mentioned that in December we'll get an update on our green plan. And since we last met, we can be under no illusion of the impact of climate change here and across the world. And today, myself, Fatima Khan-Shah, who leads the Race Equality Network, and Kate Sims, our Director of People, have written to everybody to express solidarity for staff and citizens who got linked to Pakistan, given the floods that have happened in that country, which have been devastating. We know that many of our staff are affected, and many people in our communities have strong links to Pakistan, and West Yorkshire has a long history culturally and through its people of connection to that region. So we know that climate change and our efforts in this are incredibly important, and we know the consequences of this are felt here and abroad. The COVID situation has eased significantly, but appears to be plateauing. So the number of people in beds with COVID is in the 200s and it's sort of stuck there for the last week or two. Has stopped falling from its peak of over 600 during the latest wave. And that equates to about 4% of beds. Coming into the Living with COVID strategy, public health colleagues suggested, Kev Smith, I think, at one of our meetings, for example, that we might see about 5% of people with COVID when we're living with COVID. So having 4% of beds filled with people with coronavirus feels about right. But just to say that we're probably in a position at the moment where we're less impacted by coronavirus than we have been. And also to remind Partnership Board colleagues that the last 3 waves of COVID have come at 3-month intervals. 6 of those are about 3 months apart. If that continues, then we will be expecting some further pressure later if we get if we get a variant. And then the third contextual thing is the impact of poverty and the cost of living crisis on people's health. And there's a paper later, and I know the West Yorkshire Combined Authority have written a paper about what we can all do to support people. This sort of combination of climate, cost of living, and coronavirus sets a quite a challenging context for us, because as the paper sets out, that then impacts upon things like staff sickness and infrastructure, etc. The other thing in the context that I wanted to flag was that this partnership and our Integrated Care Board now has in statute 4 things that we must consider: health inequalities, unwarranted variations in care, using our resources and delivering value for money for the taxpayer, and getting the biggest economic and social return on the investments that we make. And one of the groups of people who are most impacted by health inequalities are people with a learning disability. And I just draw your attention to the Leader Review that was published. It's an annual report that's published nationally, and you can see some of the findings in my paper, which continue to be shocking and, unfortunately for many families and people, unsurprising. And I hope you can also see that as a partnership, we continue to take this extremely seriously. And the position for us in West Yorkshire, when we've looked at previous reports, is that the impact here is different from elsewhere, and we want to ensure that that continues to be the case. So our mental health, learning disability and autism programme will be reviewing the Leader Review and making sure that the sort of findings that are in the national report. I reinforce that because this health inequalities piece continues to be fundamental to the work that we do, and you can see that writ large throughout the paper today. A couple of other things to talk about in terms of context. It won't have escaped your attention that we have a new Prime Minister. There's been lots of speculation about what that might mean for the Cabinet, and we'll find out at some point whether we have a new Secretary of State and ministerial team. That tends to have an impact in the health system, and we will wait and see what that is for us. What is clear is that we have a mandate from the government through NHS England to deliver in a particular way. We know we may get different ministers in the wider Cabinet, which might affect local government and other partners too. So we await the news with interest, particularly linked to the poverty agenda and cost of living crisis. In terms of the rest of the paper, you can see that the position for us in terms of performance has been one where we've got most people in West Yorkshire are getting good support most of the time, but a substantial minority not. So pressures in A&E services, ambulance care, waiting for mental health support in some instances, being treated out of area, etc. We mustn't lose sight of the fact that most people get good care most of the time and that our staff continue to deliver that, but a significant minority of people don't. And that's why it's important that when we get to Ian's paper, we're focusing on what we're going to do over the next couple of years, what we're going to do over the next 5 to make sure we have sustainable health and care services. In the next few weeks, obviously, we're getting ready for winter, and there's a substantial amount of work going on in that space, including players coming together to share their current plans, their pressures, where we can learn from each other, and how we can ensure that we continue to have safe services right across the winter period. Over and above that, I don't really want to say anything else as way of introduction. We are a partnership that's well developed and fairly mature. The move to statutory arrangements causes some additional work for us all in the short term. We won't let that get in the way of focusing on what really matters, which is improving outcomes for local people. Happy to take any questions or comments, Cathy.
Thank you very much, Rob. Councillor Kendrick.
Thank you very much, Chair. Thank you, Rob. Thank you for your paper. As is my wont, I'm probably going to focus on social care, and you've addressed this to some in different places through the paper. I suppose I am concerned that there are increased requests and referrals for care and support, and a lot of those are much more packages of complex needs, which is leading to greater care packages to be supplied. And against that, you know, you've mentioned the concern for unpaid carers coping financially with the cost of living, and if more and more of those need to enter a more full-time working life in order to manage it, the number of requests for care is highly likely to grow, and I think that's very much going to be the situation. And against that, we've got workforce pressures, recruiting and retaining care staff, and that applies to home care as well as residential. And a lot of the residential and nursing homes are sort of going into under-occupancy because they're not coping with the fuel and all the other utility costs and staffing costs. And you know, national living wage rate of £9.50 means that social care can't compete with some supermarkets locally that are offering £15 an hour. You know, and with the driver of cost of living pressures, one can see where staff may well go to. And I suppose against all that, local authorities through Directors of Social Care are being asked to make a budget reduction on average of 3.5%. I just think this is a whole system issue that, you know, as we approach winter pressures, I'm concerned for social care, but I'm also concerned for colleagues and partners in health, because it doesn't take much imagination to know what's going to happen if we don't get some handle on this. I don't know what the chances are of helping support wage levels and social care, but I thought I'd throw my tuppence worth in.
Thank you, Viv. Rob, do you want to respond to that? And Sue, I can see you've Sue Proctor, I can see you've put something in the chat box. Maybe you could ask your question next after Rob's response. Rob.
So I think Councillor Kendrick hits the nail on the head, really, in terms of we're an integrated care partnership, leading the integrated care system, which is jargon for joining up services around the needs of people. And we have to meet the mental, physical and social needs of people, which means we need a strong social care sector. And I think there's a short-term set of actions which we're working on collectively in places and across West Yorkshire social care. And then there's got to be a strategic plan over the next few years to try and get to a sustainable workforce, including unpaid carers, volunteers, and the paid staff right across the system. So on the first of those, each of the places and then the DASs, the Directors of Adult Social Services, are looking at what we do coming up to winter. And then in terms of the medium term, Kate Sims, the Director of People, is prioritising with colleagues where are we going to focus our efforts and energies. Because if we want people to work in the social care system, but they can get 50% more by working in a supermarket, we're hiding to nothing. And there's some serious action that needs to be taken locally and nationally, which we continue to make the point about. I don't know if Jo Webster wants to comment from her perspective. I'm picking on Jo because she's covers the Wakefield Place, is the director, covers the adult social care and community services agenda.
Hi Kathy, hi Rob. Yeah, I mean, all I can offer and add to what Rob's already said is that there is my role covers community services and adult social care, and we are planning for different roles, Councillor Kendrick, in very much around the integration, but looking after, as Rob describes, the physical, social and mental health needs. So we're looking at how we can integrate some of our community services with adult social care in a very different way, but also looking at how we can create new roles for the future, working alongside Kate and sharing best practice across West Yorkshire, offering people, placements as part of students, looking very differently around how we work with the universities to develop those roles in the future. So there's a lot happening and share across across the whole West Yorkshire place. But I think it's, with the fair cost of care exercise that's happening as well, that's going to place some significant pressures on local authorities, as you're probably aware. And then obviously we've got the new reforms for social care, which are all adding to the problem, as well as all the suggested issues that we've been talking about so far. So I think whilst there's many challenges, there's also as many opportunities. So I think we've just got to all work together very differently to be able to see those opportunities and grasp them.
Okay, so we don't want to lose the thread of that conversation, because that'd really be welcome to bring back into the last item on the agenda around cost of living and responding to poverty. We've got other questions and comments. We have Sue Proctor, then Stephen Cleesby, then Kim Shuttler, and then Councillor Susan Hinchcliffe. So Sue, to you.
Thank you. Thanks, Kathy. Thanks, Rob. Thanks for the paper and the update. And I suppose this question, and I've put it in the chat, it links to the cost of living paper and discussion we'll have later on. But it's about the vulnerability of particularly the care home sector, but actually more broadly, the voluntary and community sector and our codependency of some of those key services. And I guess currently we're at the point of perhaps starting some intelligence gathering based on data and estimates, as opposed to panic mode, which is how the media is playing it out. But I just wondered what thought you'd given as an ICB in terms of sources of assurance, and whether there is anything that safeguarding adult boards particularly and directors of adult services could do, because we've done a lot of market sustainability analysis in relation to the workforce issue, but this is another layer of risk, and I just wondered how you would want to perhaps use some of our intelligence going forward.
Thank you, Sue. Rob, do you want to respond?
I want to respond. I think there's on that. We'll pick up the offer around safeguarding boards, intel and roles. On the BCSE, you'll remember in the first phase of the pandemic, there were grave concerns from people that there'd be a cliff edge for the BCSE, given they couldn't raise any funds from retail, etc. So as you say, we did a piece of work based on evidence of what's the state of the sector and how sustainable is it, and what support might it need. And then we put additional support into the sector to make sure that services continued and they were resourced for what was required. We've also just signed up to an MOU with the VCSE, which has a fair compensation element to it, which must take account of these sorts of increases in costs. But what I'm going to suggest through the Harnessing the Power of Communities and Kim's role, is that we reinstate that work around the state of the sector in this current context to see what we're going to need to have to do to make it sustainable.
Thank you, Rob. And we'll again keep these threads going. So we'll next go to Stephen Cleasby.
Thank you, Kathy. Yeah, it's a question for Rob really around learning disabilities and autism programme. Paragraph 17 touches on some statistics which show the stark reality for this sector of the population, why this programme is so important. Very proud that in Calderdale, or actually should I say Calderdale and Huddersfield Foundation Trust, agreed about a year or so ago to prioritise referrals, planned care referrals for patients with learning disabilities. There's a little tick box and that bumps them to the top of the P2 priority list. I don't know whether all other providers in health and care across our system have a similar process in place, but I think we should aspire that that is the case. Also, so that's a question for Rob then, and also just a point to make about the Diabetes Recovery Project, which is focusing on its first cohort of patients, or patients with learning disability and autism suffering from type 2 diabetes, and a special care process around them, which I think is to be praised and to be disseminated further. But is there a similar one for patients with learning disabilities and heart disease, or neurological problems, or epilepsy, etc.? And could we think of the learning from the Diabetes Recovery Project and sort of widening the approach?
Rob?
Yeah, so very aware of the work in Calderdale and the progress that's been made. And to add to the work around diabetes and planned care, we could talk about the special clinics and support we've put in place for things like the vaccination programme for people with autism and a learning disability, which has been very successful, which I think speaks to a change in culture and mindset as much as process around recognising the vulnerability of people. Sue Proctor and I years ago did a session following the Death by Indifference review about how we should be thinking differently in this space, and hopefully we finally are. I don't know if Julian Hartley or colleagues from Wyatt want to describe where they've got to in terms of the process for planned care. I know that all trusts were committed to prioritising people with a learning disability to get to the top of the waiting list in the same way as CHFT. But I don't know if I can see Brendan on the screen. I don't know if Brendan or Julian or any of our Wyatt chief execs want to say where that's got to.
And silence, Brendan.
Well, I think it's probably to Stephen's point, this is broader now, isn't it? So we've done a piece of work around waiting lists. The next iteration of this is how do we use some of our digital capability to truly influence what we're doing? We need to understand whether there's bias before people get on a waiting list, or whether they've been seen in other aspects of the health and social care sector. And then there's something about, we talk about people often, well, they still use the language of hard to reach communities. They're not hard to reach. It's how do we work differently, Rob, in some of this. So Wyatt have had a conversation this morning about what are we going to look like as an acute collaborative over the next 5 years, taking into account some of the community services that we provide and how we work as a true anchor partner across West Yorkshire. So I think we just need to keep as agile as we can with this, because to Stephen's point, it will keep growing.
Okay.
Yeah. The other thing I'd say, Kathy, just on the second part of Stephen's question, is that this is something I think that really genuinely needs to go into the clinical forum. If you think about the genesis of things like West Yorkshire Healthy Hearts, it was great work done in Bradford, then implemented everywhere. And Stephen, it seems to me that there's something about, can we extend this beyond this disease group, into all disease groups, then into all places? And I know that Fatima Khan Shah and the personalisation programme can help with that too.
Great, thank you. And that's an example of how we take, Stephen, your point is taking best practice, sharing it with others to make sure that we're improving care and tackling inequalities. So thank you. Kim and Councillor Hinchcliffe, you're waiting patiently. So Kim, will come to you next. Thank you.
Thanks, Chair. So it's always good to come to a meeting where other people have already talked about the VCS before I get on. So thank you, Sue and Rob. You know, I'm new into post, familiar with the conversations that are going around West Yorkshire in terms of the pressures that the VCS are facing, and I guess I don't think it's an exaggeration to say it is a pretty desperate state of affairs, and we're thinking about actually how we have pulled together some emergency conversations. So I welcome Rob saying about revisiting the conversation about VCS sustainability. I think it's important to talk about it in terms of not just sustaining our sector and the individual organisation. It's about sustaining that work which will fall over, you know, this winter and lead to some significant pressures. And you know, so much of that work is invisible until it disappears. I think there's some best practice going on in places, and I'm really keen to hear more about that in terms of I know that different places took different action last winter and during COVID in terms of how they supported their sector. So it'd be great to think about that and share that. And then the other point I wanted to make is about the sector's offer in terms of supporting system pressures, and again looking at where the areas of best practice were around there. I know that there's some patches that I know about, you know, some of my experience in Bradford and Craven about specific work with the acute hospitals around winter pressures. So I think we'd really welcome those wider conversations and sharing what we know and starting those conversations now.
Great, thank you, Kim. And again, we won't lose that when we come back to the item on cost of living crisis. And as people are saying, they'd welcome sharing best practice, or we've got a good example here we want to share with others. We have a number of forums and programmes and place committees now that we can share these opportunities and this learning. But if you feel there isn't an opportunity, please let us know. It's one of the roles and jobs of the West Yorkshire team to help you find that kind of information and exchange practice with colleagues and peers. Thanks, Kim. Councillor Hinchcliffe, to you.
Thanks. Yeah, just to follow on from Councillor Kendrick, really. Everything she says, as you'd imagine, with we've history really in this partnership of being very pragmatic when it comes to cost of living and other crises that have affected our region in the past. And under your leadership, Rob, you've been able to respond quickly to that. I just sort of make a plea. This is one of those issues. I think we're in-year pressures now. There's obviously a pay increase on the table for local government workers, which is unfunded. Obviously, we know we need that to go into the sector because otherwise we're not going to keep our valuable staff. But at the same time, there are those pressures that are actually going to have a real impact on our system. So I just wondered if it's perhaps worth putting out. I noticed you've got an ICB meeting on the 22nd, and there's some of us have talked about long-term pressures, medium-term pressures, but some also short-term ones, which I think probably need some immediate attention, including care homes, which colleague Sue mentioned there. Thank you.
Thank
and the
you.
agenda item for 22nd is what I'm saying.
Thanks, Susan. Rob.
I fully support that. I think, as you say, Councillor, we've been very pragmatic and quite radical, I think, in the past in terms of the way we've all looked at managing risk collectively, including transferring real money between sectors. I think we're in those sorts of times for those sorts of conversations. Perhaps if we get Jonathan Webb as Director of Finance working with local authority colleagues, and we could bring something to the meeting on the 22nd. Clearly, places will already be having these conversations, given the delegated budgets to place and the local relationships and understanding where the pressures are. But we should approach this with the same spirit of collective risk management as we have in the past.
Thank you very much. Just before we finish up, colleagues from Wyatt, Julian, Brendan, it's only because I can see you on the screens. We've got a winter coming up with challenging. I know that many colleagues here are involved in forums on winter planning. Is there anything you want to reflect as Wyatt? We had a big conversation in June on flow. Councillor Kendricks talked about discharge, social care. Is there anything you want to share on your plans going into winter from our acute collaborative? Brendan, I've seen you taking yourself off mute, so I'll pick on you first.
Okay, well, I think there's other colleagues here, but I think the planning, we're always planning for winter. I think, Cathy, we haven't seen that seasonal variation throughout this year for all of the reasons that I think Rob described in his opening, certainly around COVID and some of the acuity of our pressures. Planning goes on. Some of this will be about what is the surge activity we could expect to see around COVID or indeed winter pressure? What additional beds could we have? The reality there, though, is how do we staff those beds? And I'm reassured to see that the winter planning we've got in place is at a place level. We're not just looking at it from an acute perspective. We are working with our partners around what would the social care model look like. But I think to the conversation, just there's a deficit in that, and there's a workforce challenge going into the winter, which is a concern for all of us. Some of this will be about the strength of our relationships and our can-do approach. I think Susan called it pragmatism, but I think that will be tested going into winter.
Okay, thank you. Len, welcome to the meeting.
Yeah, thank you, and apologies I'm late. I just reinforce what Brendan's just said there. I think it would be wrong for us just to look at this as an acute problem. We've got to look at it as a system-wide problem or issue to be accommodated. I think we've got to look for the development of that virtual bed, that virtual, that response in the community to avoid admission, but also that response in the community to get patients back to their own homes. And I think that's got to be a focus for us about getting homes rather than always looking for alternatives within social care as well. So my sense is it's about working as a system, and I know that across all of our places that's work that's ongoing. And often we get measured in the NHS around how many extra beds can we create for winter. I think it's the wrong measurement. I think we've got to start to think about how we get patients back to their own homes and support them within the environment and the communities that they live and feel comfortable in.
Thank you very much, Len. And just to note, what you'll see as our first full meeting in public for the Integrated Care Board, you'll see that we are having a focus on the 6 metrics from NHS England over the winter period, which Len is referring to, how they're measurements of acute hospital activity and ambulance service, but actually how we all work together as a system to make sure the flow works well. I know there's also a keenness of our emerging community services provider collaborative to work closely with acute provider collaborative as well. I can't see Brodie Clark here on the call, but if he is there, feel free to put your hand up at some point to share thoughts. But I'm really pleased to hear you all talk about system and place working. We've got 2 more hands up, and then we're going to move on to the next item. So Tom Murden and then Rob.
Thank you, Chair. I was just going to support very much what Councillor Kendrick and Councillor Hinchcliffe was saying, and just reiterate I think there's a huge amount of joint work going on in terms of whole system work and place-based work from Rob and the team down through each place. And some of us have been involved in some of the national discussions about this as well, to make the points that have been made, particularly around social care and the energy crisis. Just picking up, reflecting on the last point, I think one of the challenges we're going to have is that hospitals are warm, and people will be very, very challenged in their own homes to, even if there's intervention by government, which it appears there is going to be able to heat their homes and pay their bills. And we're going to have a warm spaces strategy in every place, and we're all working on that. I think particularly adjacent to A&Es probably. And a lot of us are really, really worried about the ability of people to be able to continue heating their homes and being able to have places to go back to, which is going to be an ongoing challenge. But also the financial challenge that stacks up in the care sector and back into local government is one that we're having to consider now, because of the way that the local government process works and the consultation periods required. We will be in budget consideration and setting mode already as council, so it's just worth health colleagues bearing that in mind, and any help you can give us in terms of the messaging to the centre, and I know that Rob and many others have been doing that on our behalf, would be really appreciated, because it is going to be the health system that's going to suffer if the social care issues are not dealt with and the energy issues aren't dealt with.
Thank you, Tom. Rob.
Yeah, I think it's a kind of sobering conversation we're having, isn't it? Which reflects the genuine pressures that we face. And as Tom says, if there's pressure in the social care system, the health system will feel it too. But ultimately, the people who feel it are the citizens. And I think we've all got to keep them as our first thought, really, in terms of and how we're going to deliver with that focus on outcomes, inequalities and variation, etc. I was just going to sort of sweep up with two things, really. Firstly, the winter and planning. We've said previously that we need to make sure that's done jointly, and including the points Tom's just made around council budget setting, etc. So we'll make sure that does happen. In the planning, we've been asked by NHS England through the health lens to focus on 6 indicators, but actually behind those there's 63 literally different actions that might help, is the way that it's being described. And what we're being asked to do as a system is to do a self-assessment, and are we doing those things? You know, hospital for home first type developments, for example, making sure you've got the appropriate streaming, making sure that you've got the right arrangements with the ambulance service, etc. Now, the expectation there is that if we do that well, then that's where it stops. There isn't a sort of death by spreadsheet assurance process that's required for every day of the winter. That's the promise at this point. I hope it stays that way. I can see from people's faces and past experience that there's some doubt in the room, but we'll let's hope. So maybe just for our assurance, we will be doing an assessment against all those actions and seeing where we are. I think the second thing I just wanted to remind people of is that as we're getting into this, it is quite sobering where we are, and I think others have said in the conversation that there's kind of everything's a disaster, it's Armageddon narrative being spun in different places. I don't think that's where we are. I think we're in it's going to be incredibly difficult through it position. And we can be confident about that to some extent if we work together and based on past history. But we have to be pragmatic, honest and real about the pressures that we're facing. In doing that, we have to celebrate the good stuff too. And there's some examples in this meeting today, and there are some examples that external bodies notice. So I just put a few of those in my report. You know, it's great to see Wakefield winning the Children's Improvement Award through the Local Government Chronicle for health service colleagues. That's the same as getting a HSJ award. It's great to see the number of awards that ICS and partners in places are up for in the HSJ awards. It's good to see the Nursing Times awards. It's good to see the other various things that we're getting recognised for, because people are doing good work every day. And we've really got to keep that in view alongside the significant and substantial pressures we're all under. So I just wanted to make that point to finish.
Thank you very much, Rob. And we talked about this at our last Integrated Care Board gathering as well, how we're supporting and standing with our health and social care colleagues, particularly at this time. Thank you so much for the comments in the chat box. I'm sorry we didn't get to them, but John noting on climate change and green plan. Kim, we note your request for any examples of voluntary community and social enterprise sector best practice examples on sustainability. Brian, note your point on GP practices and the issues on energy costs. And Helen Thompson, thank you very much on the sharing a very short update on the work of the Community Services Provider Collaborative as well. So we've got quite a few things that have come out of that. Anthony Keeley, our colleague from our NHS England regional team, who's embedded with us in West Yorkshire, has shared with you the 6 key metrics from NHS England over the winter period. So I'm going to move us on now. We're going to come back to this discussion at the end. So hopefully we won't lose the thread of this and the passion as well that is being shared. Thank you so much. Committed continually to our partnership, particularly at this time. So I'm going to move on now to Tom and Gareth, who are going to talk to us about the Leeds Health and Social Care Hub. So it's a slight change in the agenda. It's due to our presenter availability. We have until around 2:30 on this item. So Gareth and Tom, our colleagues, have had a document giving an overview of the Health and Social Care Hub, but would you give us some highlights? I know we're here to acknowledge the development as well as look at opportunities for our partnership.
Yeah, absolutely. Thank you, Chair, and thank you all for letting us speak today. So my name's Gareth. I'm from the Department of Health and Social Care. You know Tom, so he can introduce himself in a moment. We circulated the document in advance. I really wanted to highlight 3 things. I wanted to highlight sort of why we're doing it, what we're doing, and how we can work together to take it forward. So why do another partnership document? Why look to further embed the department in the area that it is based? And I think one of the big priorities for the Department of Health is to not just be a bunch of staff who work in an office in a city, but actually to much more integrally embed ourselves into the locality in which we're based. And it's not just the Department of Health that's based in Leeds and surrounding region. You have NHS England have offices there. You have NHS Digital, Health Education England, the CQC, Skills for Care. There is a big networking infrastructure in Leeds and the surrounding area in West Yorkshire, and if you broaden it out, of health organisations, both the national ones and of course all the local ones, including all the ones on the call today. There's also that surrounding health infrastructure. So we know that the West Yorkshire area, one of the largest areas for digital health in the country, and we recognise that not only are we based in the area, but there's a real opportunity to work closer together. And so we wanted to do something more as an organisation. We wanted to talk to partners about what that thing was, what was the best opportunity to do something. So it led to some work that we did sort of over the end of the spring and over the summer, which was working with partners in Leeds and West Yorkshire. So Rob was part of the steering group along with Tom and a few other people to sort of say, okay, what do we think we could build together? What could we look to do that is additional to what already happens and is something where we can sort of take advantage of the sort of the national and local infrastructure that can be brought together, and what can that work to do? So what does that lead to? It leads to a partnership document that is called the Leeds Health and Social Care Hub, partly for ease, but partly a reflection of that's where most of those organisations are based. But in the document itself, it reflects that it can't just be about Leeds. You can't just sort of carve off a city from the geography that it sits in. You equally can't do a number of the things that we want to achieve in that small geography itself. It needs to have that broader base. And so that's why we've been talking about Leeds, West Yorkshire and surrounding area. And we tried to sort of, as we were talking about the geography, use that broader geography and that broader understanding of the region. Some things we do will be small scale, either small in one region, small in a city, but some of them will actually need to encompass everything. We thought that there were 3 big priorities as we talked to colleagues. So there was the biggest challenge that we probably faced as we were looking at it was around workforce. We recognised the need to bring in more talented and skilled people from our local areas, to develop those people, to get a more diverse workforce, a more diverse leadership of that workforce, to continue to upskill and develop the people who are working for us, to build sort of diverse and interesting career paths that allow people to build entire careers in the West Yorkshire area, rather than, in our case, feeling like there's a draw of London, but in some of the other national organisations, the draws to other areas where they're based. We know that there are real opportunities in the health and the tech digital health economy. Some of that is to do with the fact that we are funding and building a new hospital in Leeds, but a lot of it is to do with the already strong industrial base that sits in that wider West Yorkshire region, and actually the wider Yorkshire region if you look at it in the whole. And there are real opportunities to do more in that space, and we wanted to sort of like really identify that there is a real link between the work we want to do with our organisations and the work we want to do in that wider sort of economic space. And then the third area, which I think is the area that's most novel and has the most potential for really exciting and interesting areas, is around policy and delivery collaboration. How do we work in a fundamentally different way? How do we take the big policy challenges that are being sort of discussed and considered nationally and connect them much more closely to the local delivery of those of the responses to those challenges, therefore developing better policy, but also helping to develop better delivery, and much more closely aligning the delivery and the thinking about policy in that space. We think there's real opportunity to do that. It is going to be the hardest one to sort of unstick and to work out a way of working to make it work. And the document was designed to sort of like set a framework and to set an expectation that we would try and work differently. The department would try and work differently. The big national organisations would try and work differently. We would set some expectations about the types of things that we would do, and then we would build on that to actually work out what to deliver. And that comes to how. So we want to integrate into things that already exist. We don't want to create brand new infrastructure. We don't want to create new bureaucracy if we can avoid it. We want to recognise that already excellent partnership work that happens across the region. To start small, so there are probably small things that we can do together, small things that the department can be involved in, small things that other national health organisations can be more involved in locally that can add benefit, and then to look for opportunities where we can get started. So we've already been talking to colleagues in West Yorkshire. One of the things in the document is around we wanted to look at how the department could spend its apprenticeship levy locally in the West Yorkshire area, and we're doing some colleagues in the West Yorkshire Combined Authority about how we can make that work. It's a very small starting point, but we think there are opportunities as we develop this to come up with ideas, small things where we can work together in a different way that can then deliver real benefits. So that's a really quick run through of what we want to do. This is the start of a conversation. It doesn't all have to happen at this meeting. We're having lots of conversations outside as well, but we want to use the document as a jumping off point to do more as opposed to a thing in and of itself.
Great, thank you, Gareth. And we have a number of forums and gatherings that across places and services. So I hope we can continue the conversation. Tom, is there anything you would like to add to Gareth's overview?
Just to say thanks to Gareth and the team for their engagement. I think we've tried to live up to that third area of working differently through producing this quite quickly and take the opportunity for us to have a real insight and almost foothold into the national policy making process. So I think there's a big opportunity here in relation to that. I think going on to the workforce side, if you think about it, if you're a graduate or you're coming out of school and you're thinking about what to do and which careers to go for, then the fact that we have such important national roles as part of our ecosystem is really, an advantage for us that we should be taking to, each of our local places and letting people know that, they're not just going into the local NHS and the local health and care system, but actually there are national roles involved in this, particularly on, tech and policy making side. So big opportunity there. And then on the economy, I think we've started some really good work in that area. We've done some really good, collaboration through the working with the Combined Authority, but there's a lot more we can do. So I would, this is come out fairly quickly. It's got quite a Leeds focus at the moment in the way it reads, but I think there's a big opportunity for every part of West Yorkshire to really benefit from this, and we're really excited by it, and we'd like to continue working very much in that different way. And I think we're all ears, in terms of anyone who wants to get involved, particularly the early intervention and community-based way that we all work in West Yorkshire. I do think and the EDI side more recently, I think are areas that are really, we all, I think, can bring something to the table on, whether it's Born in Bradford or whether it's the, the research collaborations that we're starting. So yeah, I just commend it to everybody and suggest that you find out more.
Great, thank you very much. And both of you have reflected how this is broader across West Yorkshire and in terms of the opportunities and the benefits. Liz, welcome to the meeting. Would you introduce yourself and then over to you for a question or comment?
Yeah, thanks, Kathy. I'm Liz Mear. I'm chair of the Kirklees Place. And thank you for this report. I thought it was a really good read, and I was particularly pleased to see the short paragraph about seconding staff into organisations and making that easier, because we've talked a lot about workforce today already, and we've always had this conundrum about can we move people easily between organisations, and that is really difficult to do. But I just thought actually making it easy for people to be seconded between sectors, share that experience, giving them new opportunities, helping them to support our residents was a really good idea, because that is a quick way to do these things, and is something that when you look at this, some of it is Leeds specific, but we could spread that across all 5 regions. So I thought it was a really good report, and thanks for bringing it to our attention. And it would be great to work on that, just picking out that one thing, it would be great to work on that to support us all across our
Great. Okay. Thank you, Liz. We've got some other comments coming through. Julian, you've got your hands up, and then I don't know, James from Bradford District, whether you want to comment as well. Julian, to you first.
Thanks very much, Kathy, and apologies, my connection dropped off earlier, but I think just to agree with what Tom's framed, and thanks, Gareth, for the introduction on this. I think the key point for me, Kathy, is that, you know, this is going to benefit, I'm sure, the whole of West Yorkshire, and the fact that it's Leeds that's been as part of West Yorkshire, and Rob was involved in the work to bring this to fruition, but very much seen as the place to be, to come, for train, to develop, and I think that's great for all of us. So I think there's a powerful message here about investing in the West Yorkshire and Leeds City region around innovation, skills, and I think it, in the times we're in, making the most of this opportunity as an ICB, as well as obviously as a Leeds place, is going to be key. So it would be good to continue to have the conversation at this level about what we're doing and how we maximise and join together all of the different threads to make sure this is a success. But thanks for the update, Gareth.
Okay, thank you, Julian. So I think we over to James for Bradford District, and Kate Sims. I wondered if you might just talk about it, because we've had reference to the people plan. I can see your comments in the chat box, and then to you, Rob, and then we'll move on to the next item. So James Drury.
Thanks for the update. It's great, and let me just first say you'd be more than welcome to come and talk to colleagues in the Bradford District and Craven partnership. I'm sure we'd love to connect on this. The thing I mostly wanted to raise was the opportunity to join up that third of those priority and delivery collaboration with the conversation we just had. You know, some of those big issues that are quite, well, some of them are very immediate, aren't they? But they're the big issues, and we've shown a propensity to be able to be creative and flexible around things. But here you've got a partnership that's big enough to be a valid test for innovative ideas, but small enough and connected enough to the partners that you described in relation to this hub to be able to try some real radical different things, you know, and whether that's around alleviation of poverty, whether that's around different approaches to social care, whether our approach to VCS and funding, etc. You know, I just wonder whether there might be one or two things that we really want to major on and try something quite different and see where it gets us to, that might add to the policy options open to government at a national level.
Yeah, thank you, James. That's kind of very West Yorkshire, isn't it? We're always up for trying to pilot and test and trial. So thank you for that. And Gareth is smiling, so that's good. Kate, then Rob.
Thanks, Kathy. Just to say, yes, I mean, looking forward to working with Gareth and colleagues. I think we have a meeting focusing on people and talent on Thursday, which would be really good about the hub. I'm obviously already really impressed with the work of the Leeds Health and Care Academy, and it's obviously in my mind, with the broader people agenda, is linking those two things together. But I think, as colleagues have said today, the work that I'm sure has been highlighted can really benefit the whole of West Yorkshire. And the example that you raised, Liz, around that flexibility of movement approach is something that you just wouldn't want to focus in one place, would you? It'd be across the system. So certainly in this role, Kathy, you know, my intention would be that where there's been great sort of work and learning, then that can be shared widely, because I know that all of the places with their people plans are all having similar conversations. So I'm sure a real West Yorkshire focus. So look forward to Thursday, Gareth.
Great, no pressure. Thank you very much. Yeah, and this is the opportunity genuinely that we're growing talent and letting people are going through their education, and then they can pass support through health and social care. That's what we're aiming to do here, isn't it? Rob, is there anything you want to share? What happens next? And then we'll move on to our next item.
So I think this is, first thing I'd say is a vote of confidence in us, isn't it? as a partnership, and us as a system, and Leeds as a place. And you know, you might not think it looking at me, but I did move up from London with civil servants in 1992 to Quarry House when it was half built. And that was a statement being made by the government at the time about moving away from Whitehall and into the regions, and separation of some of the leadership of the service away from the political sphere to a certain degree anyway. And I think what this seems to me to be an opportunity again for the Department for Health and Social Care to be looking at what's the operating model then. And what you've got in West Yorkshire is you know, the Department of Health and Social Care, NHS England, NHS Digital, a big Health Education England a group of councils and NHS organisations, third sector bodies, etc., in a system, and some providers of services. One of them, one of the best and biggest tertiary centres in the country. So if you want to look at what the operating model looks like and what subsidiarity means in this new model, where national does what national needs to do, regional does what regional needs to do, etc., then we're the ideal place to do it. So I would hope we all see this as a significant opportunity. James has just demonstrated he's just volunteered to do a lot of work, which is the kind of next steps that we're interested in, really. Who wants to have a go at something that's going to make a fundamental difference and is going to make things better? And if we've got a challenging situation or conversation that we need to have, let's have it in the way that Susan Hinchcliffe, Councillor Hinchcliffe, just described earlier in terms of the pressures facing this.
Thank you. Okay, so if we commit to bring this back on the agenda, Gareth and Tom, we want to follow the story as well as maximise the opportunities. Councillor Hinchcliffe, and then we'll finish up on this item.
Just thought briefly, an action we could suggest really is, if we've got this Chris Wormold, who I don't know, but obviously he sounds to be very important. So if we know him, could we take him on a Seeing is Believing visit across West Yorkshire to look at brilliant practice in each of our 5 authorities, so that these people who make this policy nationally have some understanding of how life really is on the front line? And I'm not suggesting we show how terrible it is, because we've all got areas of good practice, but is that something we could craft? 2 days for him to go and we all pick something that we're really proud of to show him how it works and how it can inform national government policy. Just an idea.
Great. Well, I'm nodding, but I can, yeah. Gareth, if we can explore that.
I mean, I don't know if he could commit to 2 full days, but I think he'd really like something like that. I think that would fit with what he's been talking about. So I'll talk to your office about like what we're setting up for them. Yeah, something like that. See if we can get something organised.
Sounds great. And for the tape, he's the permanent secretary of the department. For
yes, that's right. And
yes.
My boss.
And Gareth Boss. Okay, thank you very much. And this is what we're always looking for, opportunities to showcase our work. We want to continue the exchange best practice with each other, but also outside of our system as well. I just want to note, Lewin, thank you as well. You've noted about how this will work well for hospices. And when we talk health and social care, I know Kate talks in the our services and our workforce. Okay, thank you very much for that discussion, and we'll plan to pick that up again into next year at one of our future meetings. Gareth, thanks for your time, and Tom, I appreciate you may need to get off quite soon, but thank you again. Okay, so we're going to move on to our next item, which is our Partnership Board's Terms of Reference. My colleague Laura is here just to talk this through. I assume you've had time to have a look through it. This was mentioned at our June meeting, and this Terms of Reference particularly support us on a statutory footing as an integrated care partnership. Laura, are you there?
I am, yes, thank you.
Good. Would you just give us a brief overview and explain what needs to happen next?
Of course I can. Good afternoon, everybody. As Cathy says, my name's Laura Ellis. I'm the ICB's Director of Corporate Affairs. So the report, which I'm sure you'll have read, sets out the draft terms of reference for the Partnership Board. They have been revised to reflect that the board has taken on status as a statutory committee of both the ICB, the Integrated Care Board, and the 5 local authorities. They are being shared today for your consideration and any comments. We are looking for your support for those terms of reference, and the next step will then be to approve them through the appropriate governance mechanisms for both the ICB and the 5 local authorities. that was all I was going to say by way of introduction, so I'll pause and see if there's any comments or questions. Thank you.
Does anyone have any comments or questions on the terms of reference? If there's something quite detailed, I'd encourage you to put it in the chat box or to email Laura. Okay, so what we were asking for is for you all together as a partnership to recommend these terms of reference to then go to local authorities across our places and to our integrated care board. So this is always difficult when you do this virtually, but is everyone happy to recommend these terms of reference as they stand for those then to be approved? I can put that on the screen. Okay. Thank you very much. Thank you. And again, if there's any detail, I know some people look over it in general and some people go line by line. So for particularly those of you who go line by line in these kind of governance documents, Laura and I love you. And please send through any detail that you may have any comments or questions on. Okay, Laura, I know that was a really quick item, but thank you again to you and all your governance colleagues who have been working on this process. There's been setting up a new organisation and organisational change. Our advantage is that we are very well established. I know many other systems across the country, including the North, are still trying to work out how their partnership is going to work and who's going to be on their partnership, whereas here we are talking about responding to the cost of living crisis. So thank you to you all, but we'll make sure we've got the proper processes in place. Okay, Laura, thank you. Okay, so now we're going to move on to our insight report from Healthwatch. Gary, I think you're with us today. Thank you so much for joining us. Colleagues, I assume that you have had a look through the paper, the document that Healthwatch colleagues have shared with us. It's incredibly comprehensive. It's great to see comments directly from local people and service users. But Gary, what would you like to share with us today? I know you've got some recommendations from you and Hannah and other colleagues from Healthwatch. So what would you like to highlight with the partnership today?
Yeah, thank you, Chair, and thanks everybody. Thanks for inviting me to present this to you today. It's a pleasure to be here. As Kathy's mentioned, you'll have all had copies of the report that has been drawn together through various bits of local Healthwatch feedback, insight and citizen comments, commentary from each of the place levels across our region. And so that would include Healthwatch Wakefield, which is my organisation, but also Healthwatch Leeds, Healthwatch Kirklees, Healthwatch Calderdale, Healthwatch Bradford District, but also Healthwatch North Yorkshire, who cover Craven in the unique way that the local Healthwatch network is set up. Feedback that we've picked up mostly reflects the challenges that possibly pre-existed before the COVID-19 pandemic, but has been exacerbated by that pandemic and also impacted by the current cost of living crisis, as you'll all be aware. Additional challenges, though, that we're picking up on are also being felt by those who already have pre-existing health inequalities, things including poverty and additional communications requirements, and the current situation are exacerbating those inequalities. That's what we're hearing. The key themes that you'll notice we're picking up at the moment in each place are around access to primary care, NHS dentistry, support for mental health conditions, shifting to non-face-to-face delivery in an effective and efficient way, the cost of living crisis and hospital discharge processes. In the report, you'll see that we've got lots of sort of more detail that drills down into each of those areas. And I'm sure there's probably lots of things there that don't come as any surprise to the people in this board. But in summary, we're looking at things in particular in terms of access to primary care, things like booking GP appointments, lack of face-to-face appointments, variation in service delivery, both across the region, but also within places as well. Patients are reporting confusion and discomfort with the triage processes within primary care practices. We're getting lots of information regarding staff attitudes, routine checks being delayed, and people are reporting failings in the accessible information standards that they would expect to see in primary care. Dentistry, as we know, is a really hot topic nationally as well as in our region. Lots of people reporting an inability to access dental services completely and not able to register with dentists. Reports of long waiting lists, access to urgent care failings. We're starting to pick up some information regarding delays in NHS 111 service provision when people are asking for help and advice regarding their dental care, and also some information coming out regarding children's orthodontic services across the region. In mental health support, we're looking at access issues again and long waits, and also support for people that are in crisis, community service provision, and children and young people mental health services. And things that we started to pick up more recently in terms of cost of living are where patients are finding themselves unable to afford to travel to appointments, which means they're failing to get the access to the healthcare and the social care services that they need. This is exacerbating something around digital exclusion as well, because we're finding people having lack of connectivity, and things like having credit for using mobile data, which means they're feeling more pressure on getting access to the service, where things have moved into the digital domain. And then, as you're all aware, there's pressures on hospital discharge processes that we're feeling at the moment as well. But we're also similarly picking up some areas of good practice in all of those areas, and hopefully the report that we've submitted will highlight some of the good things that people and patients are reporting to us, in particularly about the involvement of family and carers in decisions about the way their health and care services are provided. So based on this insight, we have suggested a number of recommendations in our report that I would point you all towards to take a look at. In terms of access, we're recommending that there needs to be more clear and simple systems and effective communications that allow people to access primary care services and appointments when they're needed, and in a way that works for people and for individuals. The availability and length of appointments should reflect the needs of the population, and it should be taken to address this availability when there are increased demands on the system. We're recommending that people and services look at providing and updating clear and simple information in different formats about what support and services are available and how these can be accessed. Consider how to tackle variation across the system, identify good practice, and consider how this can be shared and duplicated across the region. We're also recommending a review of the communication that's put out to patients, making sure that it's person-centred, clear and jargon-free, timely, compassionate, sensitive, accessible, not rushed, all of those sorts of good things that we know we're all striving to do in our day-to-day jobs anyway. Something that's a very key theme and hot topic of my own personally is making sure compassionate care is embedded into everything we do. Compassion plays a vital role in shaping people's experience of care, and within local health watch organisations, we really pick that up when compassionate care is a thing, or when there's a lack of compassion in the care that people are receiving. Leaders need to lead by example, and frontline staff should receive good support and opportunities to develop more compassionate ways of working. And this would include supporting staff to have time out to reduce and possibly even eliminate compassion fatigue, and to ensure that compassionate care continues to be delivered. And then finally, it's just the ongoing increasing good coordination of services across the region to meet people's needs, and making this one of our key principles for delivering good person-centred care. I know that that's a real quick whistle-stop tour of everything that we've reported across the local health watch network in our region, but I would encourage you all to a closer look at the report we've published, and we've actually included lots of direct quotes that we've received from patients that I think helps make that a much richer and effective picture. And we've also added some links at the end of the document to the local health watch pages, where you can see the local place-based intelligence that we've been picking up, and some of the local reports as well that we've drawn these key themes from. But thank you for your time, thank you for listening, and happy to take any questions or points back to my colleagues in the health watch network.
Great, thank you. Kate, I wondered if you might respond, and just while you think through what you might say, Gary, your colleague Hannah, a colleague from Healthwatch, who is our representative on our integrated care board, brought recommendations as well to our one-off shadow integrated care board meeting on the 17th of May. So I suppose what I'm saying, for the record, is that we have your insights report here. We have the recommendations from Hannah. Healthwatch is embedded both in the integrated care partnership and the integrated care board, and therefore the recommendations will be weaved into our work. So thank you very much for that. Kate, there was a lot there around supporting staff, compassionate culture, health and wellbeing. I don't know if you want to respond on that, and then John, then Brian, I can see you have your hands up. Kate.
Thanks, Kathy. And firstly, Gary, I was going to just contact you to say thank you for the report. I thought it was excellent, and you've just said yourself what really brought it alive to me were the direct quotes and the references. It really felt like you know, a true description of pieces. As Kathy, you've just said that there's a lot there for me from a workforce point of view, and I was, you know, sort of making some of the thoughts there around the compassionate culture being an aspect, both in terms of, do we support our workforce effectively enough to make sure that they feel comfortable in that, but also, as you've just said, a good example of giving people time out when they need it. I think compassion fatigue is a real challenge, I'm sure, that people are under. So I'd like to sort of touch base with you separately, if I may, on some of the issues that I've read in that report. But I certainly think in terms of the wider people plan, there are a number of the findings that you've identified there that we just need to make sure in some of the learning and development aspects we've got, but also the well-being of our staff, that we've captured some of the aspects that you've highlighted in that report, but really helpful. So thank you for that.
Thank you, Kate. Yeah, I'd be very happy to catch up with you afterwards outside the meeting.
Okay, Gary, we'll take comments and questions now in groups. So we'll take John and Brian next. So John, to you.
Thank you, Chair. Thank you, Gary, for a really good report. And I think it's always useful to conduct a listening exercise in terms of what it feels like on the ground for our clients in receiving help. I think the points around access to health inequalities, the challenge of providing a standard of service that's meaningful across the piece, always difficult. And the idea of integration of services and access to health both kind of speak well to the kind of strategy. And I'm sure this will be read in conjunction with our refresh on the strategy, which we will come to. There was a point really about whether there was any additional information underneath the qualitative data or qualitative views that you provided, and how representative those views were across our 5 places.
Yeah,
okay.
So
okay.
Sorry.
Go, Gary. No, it's fine. You've just started, so that's fine. Then we'll go to Brian.
Yeah, thank you. Sorry, Chair. Yes, John, there will be lots of sort of qualitative and quantitative information that sits behind that report. The insight report presented today is drawn from lots of reports that each individual local health watch has produced over the last 9 months or so, and each health watch will also collect its own sort of demographic and background data that relates to those individual reports. So I'd be more than happy to find a way to link that all up and share that with you, and maybe produce some sort of statistics about which sort of demographic these report covers across the district.
Great, thanks, Gary. And I think my colleague Karen Coleman would welcome that to support our involvement and participation strategy, working with Hannah from Healthwatch, as well as Becky Mulby, who's our non-exec director for Systems and Future Generations as well. Thank you. Okay, we're now going to thank you, John, for that. We're going to go to Brian and then Councillor Hinchcliffe. Brian.
Thank you for this. As Peter Davis has put in chat, it's not easy reading for primary care. It's very challenging. Sadly, I think there's not much of it. There's a surprise either. I think many of us will recognise a lot of the comments and a lot of the issues that you've raised. For me, access isn't ideal, but we are still seeing more people than ever before. So there is access is available. And the face-to-face issue is being manipulated slightly by mainstream media. There were 16 million face-to-faces pre-pandemic. There are 16 million face-to-faces now. It's just a lower percentage of more offered, and there is more of this triage and online, as you've quite rightly pointed out. Workforce is a huge issue. I've been told this week that the average age of GPs leaving the profession is 39, which means they're doing 10 years as GPs and then leaving the profession. We need to make our workload sustainable, and that's got to be both for our patients. As you say, we need a variety of timings available for patients so they can get the information and the contact that they need, manner and form that they need, but also that our GPs feel they're coming away having done a worthwhile job and a good job, and they actually come away from it not being burnt out at the end of the day. So I think there's an awful lot in this to actually take forward and to work on both sides of the coin, with both patients and with practices and with practitioners. And the compassion, as Peter's also said, is really important. We do a lot of wellbeing work within your LMC particularly, and we've had conversations with James Thomas and Ian Holmes this week about how we can expand that and take that forwards. Care and compassion for our workforce and for our patients has got to be at the forefront for all of us, really. Thank you for the report. I think we just need to now get some work streams going as to how we take it forwards.
Okay, Brian, thank you for the prompt into action, and I'd welcome any colleagues who'd like to comment on the communications. Your point there, Brian, about and how we work with patients as well, that communication piece as well, and you're quite rightly giving us factual information that helps us understand appointment levels. We'll go to Susan and then Salma.
Yeah, I mean, it's the access to GPs in particular, but also dentistry, which I've had meetings about this week as well, which is coming over to West Yorkshire at some stage, although we won't have all the powers when it comes, I know that. But it really, obviously, from a politician's point of view, is what I hear a lot of on the doorstep. People are very concerned about it. It is also starting to fracture the relationship between people and their GPs, I would suggest. You know, GPs have always been very trusted, well-liked members of the community, and this is not positive really for that relationship going forward, and that is a very important relationship people have when they need to listen to that trusted advice from GPs. There's also, obviously, we've got a paper on inequalities in here, but this is a massive opportunity for more entrenched health inequalities, because already in less GPs per square mile than we do in more affluent communities, and then also you get people of disadvantage and not the people who shout loudest, and therefore they're just not going to be able to navigate their way through a more complex system to get to the advice and support they need. I think my plea would be, first of all, to check that the online support that people are being given is appropriate. I've been offered physiotherapy on the phone, for example, and it didn't work. So that was a waste of somebody's money somewhere. So there's some things that cannot be done cost effectively on telephone. Actually, it was telephone. I was offered physiotherapy on the telephone, and I've not done it. So just check that. And I think there's also, this is surely when we need to go. I absolutely understand that there's not enough GPs to go around, but we need to be. I'd like us to do some lobbying nationally for more GP practice places, for example, into medical schools, because this isn't going to get any better unless we solve that problem nationally. So there's something about articulating how many more medical students we need in the region to provide sufficient supply for the future, and whether we can co-locate services, of course, with voluntary sector and community development workers, anything we've got locally to try and help with some of those less urgent cases, which might help people in case of, I don't know, what they might have, whether it's welfare advice, debt advice, things that are worrying them. I don't know. Is there anything we can do to stem the demand, really, I suppose is what I'm thinking, rather than just try and just keep going? I mean, this is not sustainable, is it, really? And I realise it's a national issue, it's not just West Yorkshire, I realise that.
Yeah, thank you. Salma, Stephen and Tim, I can see you've got your hands up, but I just wanted to go to Rob to respond on that. So Brian, you've talked about in terms of workforce development and support of workforce in retention. Susan talking about accessibility there and integrated ways of working. Rob, do you want to respond on that? And then Salma, Stephen and Tim.
I'm going to pick up a couple of points and sweep it up, actually, Kathy, so I can wait.
Okay, all right, thank you. Salma, you're next.
Yes, thank you for that. So I'm a councillor in Leeds, representing Hare Hills and Gipton, one of the more deprived areas in Leeds. And actually, I can absolutely attest to the financial burden of access. And I think that we know, and this will absolutely be discussed in the final paper, the current cost of living crisis will amplify that financial burden for people. I have had people telling me they just simply don't have credit to call the doctors, or they can't pay for the bus to get to the doctors. So I think there's an opportunity here for us in the very immediate coming months to see how we can resolve that, because it's really an issue for those communities who are just not going to be able to access, simply because they can't afford to access those services. And I think that's a really important issue that we must have some solutions for.
Okay, thank you. Transport is a theme throughout today that we need to come to. Stephen, then Tim, then Councillor Kendrick, then Councillor Therapy, then we'll finish with Rob. Okay, thank you.
Thank you, Cathy. I'll be really quick. So yeah, a bit more about general practice as a GP and clinical lead in Calderdale. It's obviously nine pages of the report is around general practice. It just shows how important it is to the population that we get GP access correct. So a couple of suggestions. One is that I think there is some West Yorkshire funding available for integrated telephone systems that sort of manage and watch capacity and demand, so that a practice can actually detect busy points of the day when you need more telephonists answering the telephone. Because a basic requirement is that when you ring the doctor's surgery, you don't want to get an engaged tone.
Yeah.
That's all. In some practices for hours of a day, then we're getting a lot of chatter. So that's one thing. The other thing is an offer to Healthwatch, to Gary, which I think this is a fantastic report. If you want to come to my surgery, we've got 20,000 patients. We've got all kinds of things happening. We're not getting it perfectly right, but we got good at CQC recently. If you want to look and see if there's any suggestions based on the intelligence that you brought in as an offer anyway, and I'm sure there are other GPs on the call that might want to offer their practices as a way to have a look and go see, and then see if we can make any suggestions for improvements.
Great, thank you very much. I think if we get through everyone's comments, we need a full response to this report, and Gary is very happy with that offer. Tim, then Councillor Kendrick, then Councillor Ferraby.
Hi, thank you, Gary and colleagues, for the report, and really welcome it. In some ways, there's nothing new here, sadly, but I think it's a really strong and important reminder. We certainly looked at some of the aspects of the Leeds part of this, if you like, at a recent Health and Wellbeing Board development session. And I guess I struggle sometimes when I read the reports and the recommendations, because they're so big. It feels like, the proverbial elephant that we have to try and swallow in one. And one of the things that came out of our discussion was the importance of identifying a few really tangible, measurable, specific changes that are going to be made, both at perhaps a place level or West Yorkshire level, but also, Councillor Arif's example was a good one, at an even more a smaller defined area. Can we make a difference to transport in this specific place? So I'm nervous that we take a report like this and are almost overwhelmed with how difficult it is, rather than challenging ourselves back in our places in particular, but at West Yorkshire as well. And Councillor Hinchcliffe's mentioned, lobbying around and GPs is a good example of what we might do level. We need some really tangible pieces of work that we can show we have shifted. Otherwise, I think what we'll do is in about 5 years' time, we'll probably have a very similar report. And that's always my concern. We have to bite this in small chunks and start to make some real visible and tangible inroads.
Tim, thank you very much for the pragmatism there, and that feels like an action to everyone to take this report into their place committees and work through those. And Rob talks about this in his report, what we can do in the next few months, what can you do in the next 2 years, what can you do in the next 5 years. And Councillor Hinchcliffe, you're aware I've made inquiries nationally about the GP formulas are not working in highly deprived communities. We have the fuller stock take on GP services that's recently come out that we need to respond to. And Rob and I have had a discussion on how we're going to try and work with national colleagues on looking at parts of the funding formula. Councillor Kendrick, then Ferraby, and then Rob will finish with your responses. And it feels like we all want to take action on this. So what can we do next? Councillor Kendrick.
Thank you, Cathy. In no way do I want to disparage colleagues in health, but I can see them under a lot of stress and pressure. A lot of the things in this report resonate with what residents say to me, particularly, and issues like delays and miscommunication have that far greater impact on people on low incomes, missed work, childcare reasons, travel, other care and responsibilities. But I suppose one of the things I keep seeing, and I've seen it in several situations, is that where care is from more than one service, it seems to be much more disjointed now than it was pre-pandemic. And I assume that may well be because of other pressures and stresses. You know, for instance, one person who had some tests and things carried out by a consultant in February, and he got a phone call at the beginning of August, and the consultant said, "How's the medication been? How have you been?" And he said, "What medication?" Because nothing had happened, no one had passed it on. You know, people taking a test in, they've been asked to do the next day to a GP surgery to be told, "Oh, well, they collected it an hour ago, so you'll have to do another one." You know, and there seem to be entrenched attitudes at times or situations purely because of the pressures different services are under. Not a criticism, I'm just saying a lot of things in this report resonate. And somebody put in the chat it'd be really difficult to do some of the recommendations, but I think it's essential that as much as possible is done to try and work on some of those things. Thank you.
Okay, thank you, Viv. Councillor Ferraby.
Thank you, Chair. And actually, the comments that colleagues have made are actually at the forefront of my mind. But one of the things I think the problem is around, especially access to GP practices, is that the system has changed. And we all talk about communication, that's a vital part of our everyday life. But unfortunately, GP practices haven't communicated why some of the systems have changed. So telephone appointments, why you may see, when you do see a medical professional, why it may be a nurse rather than a doctor, because we've got a society that's used to ringing up the doctors, making an appointment, and you see the doctor. Now, we can all understand that you don't necessarily need to see a doctor to have your blood pressure taken or some blood tests. Stand you on the scales and say you need to lose some weight or you need to put some weight on or what have you. So we've got a systems that's changed, but they haven't communicated with the service users. Yeah. So actually the pressure and the frustrations that then go through patients into GPs practices are caused by the frustration of the patient and the customer not knowing why these changes have taken place. Now, ironically, GP practices are very good at sending out letters via somewhere down south to say you need this test or you need that test, you need your annual health check. But they don't put in any additional information, which I think is a missed opportunity. And actually also, going back to Councillor Hinchcliffe, it's about the appropriateness of an appointment for some assistance that you need. So, for example, I know someone who has a serious chest condition who got a telephone appointment for a breathing test. Now, all they asked them was, you know, how's your breathing? Are you using your inhalers? Actually, what that person needed was a lung function test, and that didn't take place. So then that frustrates them, and you know, and it rattles down because people talk. Yeah. And you go, if you do get an appointment, the waiting room is, and I've heard it myself, oh, well, Dr. So-and-so 40 years ago, you know, come out when it were raining. You didn't have to make an appointment, but you saw there were rain clouds in the sky. Come and open up half an hour later. And we've still got people that remember that type of service. And we all know that patient lists have increased exponentially, and there's a lot of pressure I think actually some of that communication could assist some of the frustrations.
Thank you, Sarah. I think that's really helpful, and I really strongly came across to me both in what I hear from people's experiences of services, as well as from the report that Gary's presented today about what we can do about communication. And we're about to change even more. We've talked about different transformations today, necessities or innovation, so we need to keep communicating. And Councillor Arif talking as well about responding to the cost of living crisis. There's something there about supporting people to access services now. Rob, do you want to respond? There's a lot there. We all want to do something, but Tim has been very pragmatic with us. What do we need to do that's really practical now and in the future?
I think there's just some reflections. So it's a really good report, thanks, Gary. And as people have said, it's consistent with people remember we've got a compendium and publish every year a compendium of what patients, service users, citizens, carers have told us about the services that they receive from Healthwatch, from various other sources, and that's available online and has been for the last 5 years. So we've got good indications of the things that are niggling people, and the latest report and the latest context is always incredibly important for us to consider. What I'd suggest is there's probably 3 things for us to do explicitly about this report. The first is just to make sure it is consistent with our engagement framework and the processes around that we've agreed previously through the board, which ensures that we have co-production and engagement at the heart of service development and monitoring. So I believe it is, but we need to check. So that's the first thing, because there's a way of doing things. We want to put the person at the centre and try to do that constantly. The second thing I think we need to do is let's have a focus on primary care, and maybe in line with the fact that we're redeveloping the strategy. Community pharmacy and general practice are the 2 biggest touch points for health and care in the system. And we've talked a bit about those. What we haven't said, and what I think we need to recognise, I think we've seen some of it in the chat, there's variation in practice. And there's also a baby in the bathwater, I would say. Now, if you look at the data, if you look what people tell us through the GP patient survey, which has just been published, the proportion of people, this is people who use GPs, you know, what's your experience of your most recent visit to the GP? How would you rate it? 71% rate it good. 15% rate it poor. And that's not, you wouldn't guess that, would you, from the conversation just had? But that 71% rate it good and 15% rate it poor. So at the moment you think, well, that sounds quite good. So there's something to hold on to here. What we should also reflect on is that data tells us that last year, that was 83% said it was good and 7% said it was poor. So something's got worse in the last year. And we need to understand what that is. What is it that's causing that kind of shift? So that the majority of people still feel like they get a good service and they've had a good experience, but there's an increasing minority which don't. And given it's the highest volume bit of the service, that's why it's so visible. And I really agree with Councillor Ferraby about the chatter then that you get, which then leads to fear, which people say, well, I'm not going to go because I won't get a good experience. Actually, you do get a good experience. And as Brian McGregor said, the volume of people using the service is. So I think maybe looking at, do we come back with the primary care strategy, which is being refreshed in the light of the National Fuller report at one of these meetings, seems to me a fundamental thing to do. And as somebody else said in the chat, it's not just about GPs. I know a national newspaper was lamenting the fact that people were seen by non-GPs recently. That's government policy, and that's right, because sometimes you do need hands-on physio, Councillor Hinchcliffe, or pharmacists to look at your medicines management processes, or a social worker to provide some social support. So it's not just about GPs. And we are doing some work with London South Bank University on primary care and universal offers in a sort of radical way. I know Becky Mulvey's on the call today, she's helping with that. So I think that's the second thing I'd suggest. The third thing is to use this as a set of tests against the strategy. So I think you can turn these recommendations into a set of tests for our strategy, which we're about to refresh, to say, does the strategy address these points explicitly? And if we can't, why not? So rather than have some kind of sort of immediate response to every single element, as people have said, these are perennial problems that we have to get over, some of which have been exacerbated by COVID. So let's use them as a set of tests for the strategy. And when the strategy comes back, I'd like us to say, against these recommendations, how is it helping them? How is it delivering against these tests? Great. So if the board agree that, then that's what we'll put into practice.
Great. Thank you very much, Rob. That's really helpful. Okay. Gary, again, thank you to you and your colleagues at Healthwatch. We'll continue this conversation, and I hope you can hear and see the commitment to action as well. So thank you.
Thanks, everybody.
Great. That leads us nicely on to our strategic refresh, where we've got an update from Ian Holmes and Esther Ashman on the progress and the principles of how we're going about the refresh. I know that you have, Ian and Esther, you have mirrored particularly the report from Healthwatch and sharing what you're hearing on the ground. I'm sorry we are shorter than time, but I wanted to invite you both just to share some highlights, and particularly this is an update to members of this integrated care partnership. So Ian and Esther, to you.
Yeah, thanks, Cathy. I'll just say a couple of things, and then Esther's going to briefly summarise the report because it's her work. I guess the first thing, and Rob's teed this up nicely, the reason we did this item after the Healthwatch engagement report item is because we wanted to understand, what people were seeing as a way of influencing the strategy. So this is exactly the conversation that we wanted to have, and this is part of the reason we've got such a close partnership with Healthwatch, so we can get that right. I'll just ask Esther now to provide a brief summary of the paper, and then maybe if I can sweep up with a couple of more general comments at the end, Cathy, that would be great. So Esther, can I hand over to you, please?
Yeah, absolutely. Thanks. And I'm just going to pull out some highlights, and I've got one quick slide I'd just like to talk through as well. So my name's Esther Ashman. I'm the Associate Director of Strategy, and I'm leading on this work with Shane Hainwood-Giles, Bilal Mohammed and Myron Rogers. Bilal and Myron are with us today as well here in the conversation. So as this is a sort of follow on from the March conversation we had to talk about the approach we were going to take. And now we've moved into our statutory arrangements. We've got a requirement to develop or refresh our 5-year strategy, and we are in a fortunate place compared to many ICSs around the country in that we do have something in place and some good relationships and foundations to work from. So board members agreed in March that we would take a slightly different approach to how we did this refresh. So we've pulled together a strategy design our representatives from across the entirety of the organisations and sectors represented on the partnership board. So it really does feel like it reflects the breadth of the partnership, and we're building systems leadership and development through the work, providing some theory, some practice around this as well, trying to create a bit of a movement to support a new way of working in the delivery of the strategy going forward. So we've co-designed the process with this group, and they have been engaging out in their own individual systems of influence, their own ecosystems in the partnership, in both formal and informal groups, and the reach they've got is absolutely quite astonishing as to how many groups they've been able to get out to, along with our support as well. We've got far and wide in the partnership and heard as many voices as possible, and we're continuing that process at the moment. We've had some great discussions in the last week with some of the health and wellbeing boards, which has been a really important step given they're the foundation of our strategy. The rest are coming over the next few weeks, and we're going to talk to Joint Health Overview and Scrutiny Committee this week as well, which will be an important conversation for us to have. Much of the planned engagement has led on to further engagement as well. People have been actually really excited to take these conversations on to their own groups as a result of hearing the conversation, which I think is a sign of the interest which is being created and a little bit of that movement we're trying to create. And it's worth saying the group we started with is evolving and growing, which again is a bit of a sign that the process we're using is helping us get to the system that we want to have in the future future so that we can deliver our strategy in a different way. So as you're aware, we've got a plan in place already that we published before the pandemic started, and it's worth just reminding ourselves that was co-produced across the health and care system in West Yorkshire. It was responding to detailed citizen engagement that Karen and her team carried out in response to the NHS long-term plan as well. It's not just NHS focused, it reflects the wider system that we're working in, which is illustrated by the membership of this board as well. So it encompasses around areas such as housing and health, trauma-informed services, to name a few. And if you've seen the guidance that's come out around the integrated care strategies, there's a lot more of those kind of things that they want to see in the strategy. So we're in a really good place for that. It sets out our 10 big ambitions, which we collectively agreed already and committed to, and it'll be important for us to make sure that those ambitions are reflected in plans across the breadth of our partnership as well, not just the integrated care strategy, but everywhere. So the whole is delivered by all the different parts of the partnership. We heard back from yourselves in March that the 10 big ambitions are still really relevant, and that's resonated with all the conversations that we've had so far. And so we're not planning to move far away from them. And to be fair, the data and the evidence that we're getting so far is certainly supporting that those ambitions are still really key, as you would expect. So given that, the process is less about refreshing the strategy, but having a plan more as to how we might work differently in future to deliver that strategy so that we can make sure that the impact is really felt on our populations. It's also worth mentioning that an important part of this work is understanding the progress we've made so far against our ambitions. That work is underway, and that will form a key part of our development of the Integrated Care Board's joint forward plan around that as well. So if it's okay, I'm just going to share one slide which will just do a little bit of an explanation as to how our priorities and our plans are nesting together, and it's quite helpful to understand how all the parts of the system fit. So this has just got a few different elements around strategy and delivery. So in terms of the strategy, we have the West Yorkshire Integrated Care Strategy, which is owned by this board, and it represents some of those wider determinants of health as well as traditional health and care. It's built very much from the foundations of the health and wellbeing strategies from the places, so is therefore built from their needs, the joint strategic needs assessments. We need to get stronger around the delivery element, and quite a lot of the conversations we've had today actually fit into the delivery, and some questions raised about that. That's great, but how are we going to make sure we do these things? So in the autumn, in October, we will get some guidance around producing a joint forward plan for the next 5 years, which is an integrated care board plan, and it asks us to do the NHS elements of delivery of the integrated care strategy. We also do at the same time operational planning, the Better Care Fund, the winter plan, financial planning. And what we need to get better at is how we connect all of those things together so that we can A, deliver that integrated care strategy, but also B, be able to measure the impact of that. Equally at place, we need to also demonstrate some of that delivery. At the moment, we can articulate the delivery against the 10 big ambitions at West Yorkshire, but less so as to what's happening in the places around those things. So we need to be able to have some local place plans that will be part of the committees, the place committees of the ICBs will be having those plans to demonstrate the delivery of their own joint forward plan. On the right-hand side there is also the strategies that will support us in the delivery of that. And someone mentioned at Clinical Forum this morning that perhaps enabling is almost perhaps not a strong enough word around how important these strategies are. And I think that was probably a fair comment. But they will provide us with that support to deliver. So we've heard a lot today about the people strategy and about having people at the heart of everything we do and having the workforce we need. Equally, the equality, diversity and inclusion strategy, the involvement framework, so we can hear the impact of how our plans are landing with our populations, and the finance strategy. And the difference this time is being that our strategy is not finance led. The finance strategy is supporting delivery of our plans and our overall strategy. So I just thought it was helpful to show that nesting there. So lastly, given that insight and evidence from our people and our partners and our data, and hopefully you'll see from the report, what we're getting back from our partners is very similar to what the citizens are telling us as well. that we can start to see what we think it's likely to mean for our strategy. So we know it's going to mean embedding tackling poverty and the cost of living crisis through our 10 ambitions and making sure we actually do have some tangible action around that. We know we need to strengthen our children's, young people and families' ambitions so that it's more focused on poverty, access to crisis services, and then we also know we need to refine our climate change ambition. It doesn't quite reflect at the moment how we want to be able to drive forward these changes in West Yorkshire. It's very much about certain elements of climate change. And we want to be able to have more of a life course approach. So really going the whole gambit of life in terms of also looking at how we have good end of life care as well, which perhaps we've not got enough of in our current strategy. Then also bearing in mind, we've heard dental mentioned today, some of the access to services that will be coming to us over the lifetime of the strategy. So dental, optometry, community pharmacy and some bits of specialised commissioning. We need to make sure that we're really got that strongly in our strategy. And we need to make sure our operating model will support us in the delivery of this. And then lastly, making sure we've got some very strong enabling strategies, and the leads for those are part of our strategy design group as well, which will hopefully make sure that we do get all of that connectivity right. So that was a very quick answer through. I don't know whether you've got anything you want to add, Ian.
Yeah, thanks, Esther. That was really helpful and really clear. I guess just reflecting on the conversation that we've had, really, I think there's something in this strategy about how we balance ambition versus sort of the reality that we're facing. I think, one of our founding principles as a partnership is that we want to be ambitious for the staff we employ and the people that we serve. But the conversation that we've had, prompted by Rob's paper and Gary's paper, really tough. And if we produce something that doesn't resonate with how people are feeling and how staff are feeling, I think we'll have got it wrong. So I guess we're looking for your help to help balance that as we start to develop the document itself. We had quite a helpful conversation about this in the board of the ICB development session last month, where we were talking about what are the conditions for success, what do we need to have in place for this stuff to really work. I'm really taken by Tim's suggestion of, can we pick a bunch of things that we know work and take really bold action on those. We probably also need to think about 5 years is quite a long time period, so what might the phasing of priorities be over the 5-year period, recognising that there'll be some short-term things that we have to do and maybe a bit more flexibility in the medium term. So I think if we could think about those things as we're having a conversation about this too, but we're really interested in your thoughts and ideas, please.
Okay, thank you very much to you both. Mike.
Hi, you won't be surprised to hear me say this as a finance person, but I welcome the fact that you're saying that perhaps it's not doing some of those enablers justice to just refer to them as enablers, and particularly in finance, it should be a priority in its own right. It's one of the triple aims. It's one of the 3 triple aims, isn't it? And that is more and more important given the fact we're getting back on the efficiency horse supposedly post COVID, and it kind of ties back to points earlier on in the meeting from local authority colleagues around how do we make sure as a system that we're getting the best allocative efficiency of all of the resources available to us. So not just talking about finance, so we're talking about environment and buildings and everything at our disposal. So I would really support the unashamedly raising the profile of that in our strategy. Yeah, I'll leave it at that.
Right. Thank you very much, Mike. And I know that having worked with you, there's also the comments that were made earlier about how different types of money are pooled within alongside services and across places as well to maximise opportunities. So, which some of our elected official colleagues were talking about earlier. So thank you for that. We've got Councillor Kendrick and then Helen Hurst, and then we'll take a break. Councillor Kendrick.
Thank you. I suppose picking up on where Ian was with that about reality, ambition and reality and how it matches, I suppose I'm interested as to how we're going to find the resources to achieve some of these ambitions. Access to dentistry, access to mental health services, warm homes, beds for families on a low income and so on. It's just a question, or it's something to be considered, really.
Yeah, thank you, Viv. And that's where we have to think differently, radically, challenge each other, don't we? Particularly as we work together across our places and our provider collaboratives. So thank you. And Ian, this is where coming back to your point and Tim's point earlier is where do we prioritise and where do we focus in the short, medium and long term? Okay, thank you, Viv. I can't answer that question today. We need to, but this is what we're point of being a partnership and working together on this, isn't it? Thank you. Helen, and then we'll go to Rob and then to back to Ian. Helen.
Okay, thank you, and thanks very much for the paper. And apologies, my comment will seem a little bit like I'm slipping back into a bit of my old role, perhaps. But I think what's, you know, certainly I think there's a uniqueness about West Yorkshire that I'm not sure is quite captured in the way we work in here, and I know within the sort of enabling sort of work strategies, I'm not sure if that sort of broader organisation development, system development is really, will get lost a little bit, maybe if it's sort of subsumed within either people's strategy or involvement frameworks or whatever. And yet that is so key and critical to how West Yorkshire operates and its success. How its operating model sort of comes to life through the place committees, through that subsidiarity, which I know gets a mention, but then it doesn't quite get a follow through, and into our communities and that operating environment that sort of starts, you know, right back in people's homes. So I just thought it had lost a little bit of that in its sort of iteration that could. That is really important to us and been an important part of our journey, and I guess I'd probably like to see it still in there a bit.
Great, thank you, Helen, and maybe our colleagues can reach out to you afterwards. I know now in your new provider chair role, just to get your feedback as well as the history that you hold. Thank you. We can take that on board. Rob, do you want to comment?
So just good to have the comments so far, and I think Helen and Mike and Councillor Kendrick made some valuable contributions. I think this point about how it feels here and how it looks for people is going to be really important to capture. You might have seen some of the coverage of the One List review, which was written in 2002. Everyone's going to shake their heads now with what you're on about. But in 2002, there's a big review done around how the future of the health and care service will depend upon people being fully engaged in their own health and care and us seeing them as partners. And it's been in the news because it's 20 years since it was written, and it said in 20 years' time it's going to look like this, or if it's going to be sustainable, it needs to look like. And I think that there's a really strong sense of us changing the dynamic with citizens and seeing them as partners. There's a really strong sense of us seeing that sort of joined up set of services based on people's own needs. As Councillor Kendrick says, to have somewhere warm to put my bed is primary in my thoughts, for example. And some of that needs to be captured. And that means that some of the built environment piece probably needs to be captured. And I think at the other end of the spectrum, we've talked for a decade or so about how do we make West Yorkshire the place for innovation in digital and medtech, and that needs to come through. So I think all of those will be picked up. Some of that will require us to work more closely with the Mayor and the combined authority, I would suggest, and that probably needs a look. Okay,
thank you very much. Ian, do you have any final comments, and then we'll take a break?
Yeah, I'll be really quickly. Thanks. Thanks for the engagement in the comments. This isn't a one-off opportunity as ever. We're out and about speaking to health and wellbeing boards, etc., and getting thoughts and views from those processes. I guess just on your comment, Helen, I think it's fair cut. We probably could have mentioned the sort of the OD piece more strongly. As it absolutely is happening. You know, Joe Farn is carrying on with the work that you started, and Kate Sims is picking up that mantle as well. So it's in there. We probably just haven't described it. And I think the process that Esther's designed with Myron to bring folk together from across the system and across the sectors to do this absolutely feels like it's West Yorkshire. We probably just haven't articulated that in a paper that's got a bit processy at times, but it's really, really helpful comment, and thanks for the engagement on it.
Okay, and if colleagues across our partnership feel that they haven't had that opportunity to engage workshops and discussions and conversations, please let Ian and Esther know, because we want to make sure this reaches out to as many people as possible. Ian, on behalf of a number of provider chairs, I'm going to make quite a provider chair statement about metrics and how do we know we're making progress and how do we know this is successful. So I know you, Esther, and I with Rob have had conversations about marking the progress today, what's working, what needs developing, and how we're going to mark the look at the metrics, particularly the outputs and the outcomes going forward. And I know that will come as the refresh is finalised and brought to us in December. But I think many of us here would just want to know it is working and we're going in the right direction, and we can point to things to know that these are markers of success. So I know you're working on this at the moment, but I wanted to just draw out that piece.
Absolutely, Kathy, and it's happening. I mean, I think the reality check is going to be that a lot of these things have gone in the wrong direction since 2019. The first three ambitions are about inequalities. We know things have got harder for people and things have got worse in that sense. So I still think they're the right ambitions. I think they're the right sort of metrics supporting them. But I think the reality is that those ambitions are now much harder than they were 3 years ago because of what we've been through. So I think. Just understanding that context, and it's back to this kind of ambition versus reality point, I think, isn't it, is important.
Yeah, thank you very much. I know we're going to talk further in integrated care board sessions as well. There's a lot of discussion emerging around shared care records, what's working, where the gaps are, where we need to develop further as one of our symbols and ways of working together on integrated care. So thank you, Esther and Ian and many others. Thank you so much for your work on this. And the action from this is that we'll see the final version at the December meeting, I understand. Okay, thank you. We're running a few minutes behind, but it's probably quite good to take a break because you've been sat here for a couple of hours now. So if we take a break and come back, I think it's 3:32. So if we come back around 3:36, 3:37, let's take a quick 5-minute comfort. And then we have our last two items. One, our standing item on tackling health inequalities for Black, Asian, minority ethnic communities and colleagues, and then the document on alleviating poverty. So see you in a few minutes, and hopefully that's a welcome break. Welcome back to the meeting. We have 2 more items now to go partnership meeting. Our next item is a standing item on tackling health inequalities for Black, Asian, minority ethnic communities and colleagues. And I'm pleased to welcome Fatima, Joe and Kenise to the meeting today. Thank you very much for the progress report you've provided. This is really helpful for us to see a plan in reality. And I know you want to do more as well. So what would you like to highlight with us today? In particular, do you have any requests for the partnership?
Thank you, Chair. So good afternoon, everybody. My name is Fatima Khan Shah. I'm one of the Associate Directors here in the partnership and one of the Directors with the lead responsibility for the oversight and delivery of this independent review. As you'll see within the report, which has been drafted by the amazing Joe Farn with our People Director, Kate Sims, what we've tried to do is, and we've got a power deck slide to go through, give an overview just to provide the board with some assurance about the activity that's taken place over the last 6 months, focused on themes 1 and 2. So just to give context to colleagues that are new to the partnership board, the review itself contains 4 areas of focus. The first is safe access to work for our colleagues. The second is the leadership, which is reflective of the population of the West Yorkshire communities. And the other 2 areas are designing and delivering services that are inclusive of our population and meeting their diverse needs, and a specific focus and emphasis on mental health. So we alternate every partnership board on those areas. We're focusing today on those first 2 themes, and the lovely Joe is going to give you an overview of what we've been up to, and it's going to be epic. Over to you, Joe, and then Kenise will be coming in to provide some feedback from our independent BCSE Voices panel. Over to you, Joe.
Thanks very much, Fatima. Hi, my name's Jo. I'm the Associate Director for System and Leadership Development at the Partnership. Oh gosh, you've teed me up now, Fatima, no pressure. I'm just going to share some slides, and yeah, I've heard you, Kathy. I'll stick to time, and keen that we've got plenty of time for discussion and questions. Once I've done my little bit, I'll hand over to you, Kenise. So I'll just share some slides, if that helps. Summarise the report that you've had. Fatima, can you see those?
Yes, I can, Joe.
Fabulous. Yep. Let me just put them on full screen. Oh, it's not doing full screen. Oh, okay. So I'll just wait for these. So I just wanted to emphasise was, whilst it's me here and Fatima and Kenise talking you through this has been an effort of distributed leadership across the entire partnership. So pretty much this has touched every organisation, every place, every team. So it's been a real collective effort of subject matter expertise and lived experience. So, and a real shout out to our colleagues on the Race Equality Network. Again, we wouldn't have been able to do any of this without them too. So Fatima's talked about the themes that we're covering, so I won't duplicate that. I'll just draw out some real examples of the work, the massive amount of work that has been going on in the last 6 months to respond to this. We've really early days in COVID, we developed a suite of bespoke health and wellbeing resources, and you'll be familiar with the Can You Hear Me podcasts. We keep adding to this, so that's a feature now in our business as usual that we will keep updating. Just to pick out another couple, Kirklees and Calderdale are doing some great work on developing a compassionate, inclusive leadership programme that will eventually be available for the entire partnership. So watch this space on that. And then if I pick the last one, the response to COVID has been immense in places as well. So lots of examples of bespoke outreach support to local communities. And there's an example there of the Queen Elizabeth Vaccination Centre in Wakefield. So tons and tons under improving access to safe work, recommendation 1. More on this is about widening participation and job opportunities for colleagues and communities. And there's a raft of examples of this that are underway. So we're in these. So an example being the Step Into Health boot camps that we're about to pilot. Calderdale are doing that with us. I think there's about 200 places for that, which is fab. And again, the ambition is to spread that once we've tested it. We've got the Mental Health Learning Disabilities and Autism programme working closely with VCSE, which is about the appointment of an inclusion and recruitment coordinator, which is hosted by Touchstone. And that's all about working across mental health trusts to support recruitment from underrepresented groups. And then I know some of you have been involved in this, the Breaking Barriers Innovations partnership that we've got, which is across the partnership. Health Education England, WICA, NHS England are in phase 2 of an initiative to create local jobs for local people. Liverpool, and again we're going to be piloting in Wakefield, which is about to start in the next couple of months. So tons of examples there. There's even more in the paper. The third recommendation under improving access to safe work was about the risk assessment process and in ensuring that every individual had a personalised risk assessment. That has been reviewed across the entire partnership, and there's lots of themes that come out of that and learning for improvement of that process. And then the fourth recommendation is about how we communicate with colleagues and the recognition of the impact of racism on people's lives. And I know that all of you are well aware of the anti-racism movement, Root Out Racism, which speaks for itself. I won't say too much more, but again, an epic effort across the partnership. Theme 2 is about the leadership being reflective of communities. And the first recommendation under that theme was about increasing fairness and equity of access to roles in response to the disparity that we know we've got between the success between shortlisting and recruitment of white colleagues and our colleagues from diverse backgrounds. So we've done a whole-scale redesign of recruitment, our inclusive recruitment blueprint and toolkit. Again, it's been a cross-partnership effort. We've taken the best of what works and added some extra magic to it, and it's available now. In fact, it launched this week, which is really exciting. So please access that and use it in your organisations. Thank you to Bradford Place that have worked really closely with us on that and are piloting it as we speak. Next recommendation was about providing development opportunities, and there's absolutely stacks of work that we've done on this. So we've got ILM5 coaching programme that's underway, reciprocal mentoring that I know some of you are directly involved with, so thank you for that. We've got a suite of resources on racial inequalities. We're going to refresh that and relaunch it in October with in conjunction with Black History Month. And we've got some legacy work from the Connected on Inclusion Week that we had in October as well. So lots of activity on development opportunities too. The next recommendation was about, again, reducing the disparity in the disciplinary process for colleagues from diverse backgrounds and white colleagues. Again, there's a difference between the amount of people that go through these processes. And some trusts have tested having an independent discrimination panel prior to any process commencing, which has shown some really positive early results in reducing the amount of formal processes that happen. What we want to do next with this is spread that across the partnership and share learning about what works in terms of implementation. And then I think this is the final one, and leaving on my absolute favourite one, which I'm directly involved with, is the fellowship programme. So again, thank you to everyone that's made that happen. Cross-partnership effort again. You can see the picture has got our first group of fellows graduating with their mentors and placement managers. So we've finished cohort 1. We're continuing to support those people to get into either more senior posts or enable their career aspirations and trajectory, and around about 8 of them have been successful in doing that so far, which is fab. Cohort 2 are halfway through, so they're just starting their second 12-month placements, and we're really paying attention to how we evaluate the programme next and what the alumni offer is as well, which is due to launch in November. And it'd be remiss of me not to mention our Race Equality Network, because I can see Fatima on the screen. So we've got an event, haven't we, Fatima, in this month? In fact, it's September now, isn't it? In a couple of weeks, to just review our operating model for the REN and take a look at, again, what skills, experience, development opportunities do our Race Equality members need. And I think that's it. So yeah, that's just the summary, which I won't labour. I'll let Kenise summarise our VCSE Voices colleagues' views. Thank you.
Kenise.
Are you there,
Hi
Kenise?
everybody. Can I have my slide?
Is it there? I've moved it.
Oh yeah.
Can you see it?
Yeah, I can. A huge amount of work and progress has been made on themes 1 and 2, and we want to really thank the teams. We know that it's been a lot hard work over the last 6 months. We particularly wanted to highlight the reciprocal mentoring programme, the fellowship leadership programme, and especially on the work Health Education England is starting to do on the barriers for colleagues to access apprenticeships with provider organisations such as schools and colleges, because education needs to be involved in this. This is something that we know is a barrier about apprenticeships and young people being able to access them. Analysing data on this for West Yorkshire would be a positive step forward. The redesigning of the recruitment practice to be more inclusive is welcomed, and we hope that it can be built on as members experiencing recent recruitment processes experienced barriers. We revisited the data pooling for all the res data at West Yorkshire Health and Care, including similar data for local authorities and VCSE partners. We know this will take time, but we will keep this action open so that we can share best practice across the region and probably across the country too. We wanted to congratulate Karen Coleman and all those that were involved in the Root Out Racism campaign for being shortlisted for the HSD Awards 2022. And we have last week contributed quite robustly to the West Yorkshire strategy refresh at the end of last week, and we will try to stay involved as much as we can as it evolves. Thank you.
Thanks, Kenise. So in summary, Chair, obviously we're coming up to now 2 years on from the beginning of the review. And I think what this summary and the previous summaries demonstrate is that we've managed to make quite a lot of progress despite all the challenges that people are seeing on the news and in the world itself. And that is solely due to the commitment and support from the leadership of this partnership, but also the infrastructure. What I would say as a caveat is, are we meeting our Sheila test? And quite frankly, we don't know, because we need to be able to understand from a business intelligence perspective whether the work and action we are taking is delivering the outcomes that we committed to when the review was implemented. And I think the other thing I would say as well is that although we've done quite a significant work on ensuring that our system is reflective of our communities within West Yorkshire, the outputs of that and the aspiration behind it was to ensure that our services are as inclusive and accessible as possible. And during current times, just reflecting on some of the feedback from the board earlier, particularly the Health Watch report, there are a number of areas by which the work in the review could be further amplified in other areas, and taking that learning forward to ensure that the services that we deliver are the best possible for everybody who lives in West Yorkshire. I'm going to pause there, Chair, if I may, and take it over to questions. Thank you.
Great, thank you very much for the presentation. I know, Fatima, you and I had an informal catch up this morning. You're saying information, data, case studies that will come through as you provide these progress reports as a standing item. So thank you. Great, thank you very much. Michael, you put a comment in the chat box. Would you like to ask that directly to the team?
Well, it's not a question really. It's a thank you for bringing me in. It's not a question, it's just a comment. I mean, I think for all of these things, you know, aligned to our ambitions, data is really key, and the data being available to democratise and being available to all partners and visible, and particularly for these, you know, priorities. If we can't get, if we don't understand the baseline and we can't measure, then we're not really serious about it. So I think data is like a really fundamental foundation for all of this work.
Great, thank you. Fatima and Joe and Kenise, do you want to respond on that, on data and in data intelligence?
I mean, unsurprisingly, I always agree with Michael Crowther that won't be new information. I think the challenges that we've had, and we've discussed this previously at Partnership Board, is the fact that we do not report consistently on the same things as the partnership. So the voluntary community sector, social enterprise measures different things to our local authority. Even our NHS providers sometimes measure different things. So we sometimes hit targets and miss the point, which I think is what Michael is alluding to. Our hope is hopefully when we come back in December with a review of where we are 2 years on, as a review, one of the things that we'll be looking at is how, now that we are a formal structured ICB, we can work with our local places and use infrastructure effectively to be able to get that data and start to be able to demonstrate that the work that we're doing is having a meaningful impact and seeing the change that we all want to see. I think Kenise wants to come in as well, Chair.
Yeah, Kenise, do you want to come back in?
Thank you, Michael, for that. I think we're persistently asking for the data. That's why we're asking for a pooling of the data as well. We want to have the data all in one place so we can compare, contrast, and then use the positive examples. And we keep on revisiting that every 6 months, and then every 3 months when it's the other priorities that we come across. So it is something we're continually asking, and we're not going to be moving that from our agenda. We're just going to keep on requesting it until that piece of work happens. What we do know is that this is not going to happen overnight, and we've got to manage our own expectations around that as well. That this, what we're requesting is going to take a huge amount of work, and we've just got our directors in place, haven't we, recently?
Thank you. Jo, do you want to respond? And then we'll come to Kim and to Rob.
Yeah, thanks, Kathy. I mean, it really chimes, does that, Michael? It extends beyond this work into the wider people directorate priorities as well, and probably even further across the entire strategy, doesn't it? That's why in the kind of report I've said that in this next phase we need to pay attention to evaluation of what initiatives are having the impact. We've got an absolute raft of initiatives there, haven't we? Which are the ones that work? We don't yet know, because exactly to your point, and it really kind of chimes with the work that we're doing on prioritisation as well. You know, so can we continue to deliver that raft of work? We can complete it, but can we keep delivering it as business as usual? Not sure. So what I think we need to do is, in this next phase, really work out which of these things are the ones that are working and do more of them. But we're going to need some help with that. We need some support. We need capacity and capability.
To the leaders who've driven this forward, I think it's exceptional in this time. I wanted to bring it back to, you know, building on some of the stuff that Kenise was sharing from VCSE Voices, and, you know, and link it to the previous agenda items around VCS sustainability, because I think it's crucial, I think, that we recognise that in West Yorkshire, the majority of the VCS organisations who have got amazing specialism focusing on working with some of our minoritised communities are the teeny tiny grassroots organisations who do not have the infrastructure to weather the storm. So, you know, when we talk, you know, we've got quite a perverse situation, really, is organisations which are larger can find more money. They've got the infrastructure to bid for more money. They can influence, they can be in the spaces to get the money that is required to sustain those services. So we have, I guess, you know, in that piece that we might pick up, Rob, about the VCS sustainability, to have a lens on thinking through what that looks like in a sort of a targeted way, recognising some of the communities that might be most likely to be impacted in this, you know, this coming period, is something that'd be really, really keen to do, and look at that with some analysis, some data, and also thinking it through in terms of what infrastructure might support this, you know, this next period.
Okay, let's take that forward as an action. Thank you, Kim. Rob, do you want to wait to the end, or do you want to come in now?
I had a couple of points on the points that have been made now. I'm happy to come at the end or now, either way.
You can go for it now, and then we'll go over to Councillor Hinchcliffe.
So on the data, I just wanted to remind everybody that we've got RES data, Force Race Equality Standard data, across every NHS organisation, which is pretty good data, and paints a picture which is not a good one. And we have made improvements in some places on that data, and we've got staff survey data, which gives us the sort of qualitative side of things in terms of how people feel. So the RES data tells us, you know, the facts around how likely you are to be recruited, how likely you are to be promoted, and all that sort of stuff. And there's some real good progress on that. And then on the how does it feel from the staff survey, it's not so good. So let's be honest where the data problems are. I think there's a problem in the VCSE, as Kim said, because the infrastructure is not there, and in councils people do things differently. We've talked about this too often now, I think. So I think we need a resolution to it, and we should probably make a commitment today that we're going to have a resolution to it. That's my first point. The second is our experiences in the Integrated Care Board as an organisation of the inclusive recruitment toolkit is a really positive one. So for the teams that are using it, they've been successful at getting staff, and other teams who've used more traditional routes have not been successful. And if you go back to my report and the position on the economy, we've got double the number of jobs being advertised every week in West Yorkshire than pre-pandemic. So the job market is quite tough for us to recruit from. So any advantage we can get from using the inclusive toolkit, we should take. So again, I would want us to, as Lewin's described, I would want us to all adopt it if we can, and see it as advantageous. out of that going to be? And Kate can help with that, I think. And then the third thing was just a question. So from the presentation, Joy, you talked about independent disciplinary panels being implemented in some trusts, but not others because they found it challenging. What's the way? Is that going to be left there, or is the plan to implement it everywhere? I wasn't clear.
Yeah, the plan is to implement everywhere, Rob. I think part of that challenge has been capacity and part of it has been complexity of the ask, but some have implemented it. So the next step is to get the people that have implemented it together with people that haven't yet, share the learning and look at rolling it out. So yeah.
Okay. So Susan, we will come to you in a minute, but colleagues, there's a request here, one, to provide data, provide the business intelligence that's required to progress this work, and we're asking everyone to commit to that. Some people have been able to, and it's easier for others, but please can you commit to that? And please can you commit to adopting the toolkit, which Luna talked about, which is in the document as well, which has been trialled. And Joe, you've talked there about how we can support each other in doing that. And if you haven't provided your information, or if you haven't tried the toolkit, support will be given and learning from others would be available. Are colleagues happy with that as a partnership to take that on board across places and services? Okay, I can see nods. If anyone has, sorry, another event's coming through on my system. If anyone has got any queries or concerns about that, please contact Rob, myself, or Fatima, or Kenise, or Joe, and we will aim to address those. And particularly if anyone's facing any barriers or issues, we will aim to remove those. Okay, thank you very much. Thank you, Rob, for raising that. Councillor Hinchcliffe.
Thank you. Yeah, I mean, I think Rob answered a few of my but I was wanting to make sure really, and I don't know the NHS system well enough to know how well embedded this is in each of the streams that we've been talking about today, like the workforce stuff and everything. So obviously we have it as a separate paper, and obviously there's always an argument, can you do separate or mainstream it within, you know, the standard papers that we have on other things? And it's always a bit of a debate, you know, if you don't talk about it as separate, then it sort of lowers its prominence really. But I suppose we're wanting a bit of both, aren't we, really? So it would be good to make sure that everybody's embracing this as part of the day-to-day work. I noticed I was just checking the Leeds one, the Health and Social Care Hub, and it is mentioned in there about diversity and inclusion is not as strong as we'd like it to be, and it is left to partners to do that, and therefore partners also need to be mindful of this work going forward, as well as their own work, I'm sure, that they're doing in their own organisation.
Great, thank you, Susan. I was wondering the same thing as well, so calling our colleagues as well and wider partners to work in this way. Thank you. We will continue this conversation, we will continue this reporting. We have asked everyone to pledge and support around business intelligence and around adopting the recruitment toolkit. I think, Joe, let's make this as easy as and accessible as possible for people to make sure they can get to sessions or gain the information. A request for me is how we link to the messenger review and the recommendations that have come out of that national report, which Linda Pollard from Leeds Teaching Hospital has been involved with nationally. Because there is a strong recommendation out of the small number there around improving equality, diversity and inclusion, which then links back with what Councillor Hinchcliffe was talking about there. Okay, thank you very much for the continuing work, and I think we're all learning as we go, and it's great to see the progress. Thank you. Okay. We're going to move on to our last item, which we have referred to throughout this meeting, and we begin with a film on patient and public voice, and Debs, you're with us shortly to introduce that film, and you've all had a document on the role of the partner to alleviate the impact of poverty. A number of us have been taking notes throughout because there's a number of ideas and suggestions and practical things that we can do together, which have been referred already in this meeting today. Now the film we have is provided, I know Debs, you're going to do an introduction in a moment. It is not our usual West Yorkshire film, but we're using it as an illustration to support our discussion today. So Debs, I'm going to hand over to you. We hopefully have a good 20-25 minutes for this item for both the film, an overview of the report, but then hopefully a really robust discussion and agreement of actions going forward. Debs, to you.
Thanks, Cathy. So, yeah, good afternoon, everybody. I'm Debs Harkins, Director of Public Health in Calderdale. You've all seen the paper, but I guess before we get into that and get into the brief highlights that we're going to share and then the discussion, you know, it's really important that we understand the human cost that poverty is having and the increased cost of living is having on our communities right now. So what we want to do is show this video from the Joseph Rowntree Foundation that just gives voice really to some of the key challenges. So we'll, if we can, Lauren, if we can get the video played, thank you.
Food banks,
deprivation,
not having access to certain resources that make life livable.
For me, poverty means no money.
I think that it means many different things, and that will also be different to different people.
So 1 in every 5 people is living in poverty in the UK.
1 in 5. Well, that doesn't really surprise me. There's 5 of us in here. I'm the one on camera, so I guess I must be that one. Fun times.
I grew up in an actually affluent part of Glasgow. I knew we were poor because I was hungry a lot. I had to have cupboards when there was a hole.
My husband walked out. I ended up with just my pension and no other income.
For me, I became homeless at the age of 17. 2 months after my dad died, I didn't have any income.
When you don't have money, you don't have control over your life.
I have to prioritise a lot. I can't just plan a normal day. I can't even plan to definitely meet somebody in a week's time because I might have no money left by then.
Your life is more about surviving, like getting through each day as opposed to actually just enjoying things that you're doing.
I don't know what is luxury anymore. Everything is luxury when I have food in my house, and if my son is happy, this is luxury for me.
I've got to make the decision to either eat or not. A basic element of survival in life, and I can't choose that on a daily basis.
It's constant, it's every day. It's always, have I got enough money in my account to feed my son for the month, clothing for the month, you know, something like a birthday comes up, that messes totally with your budget.
The bills are coming, electricity, gas, water bill, council tax, and then you pay for a school lunch. The sports club of school is £20, which I can't afford. And I feel like I'm unable to be a good parent for him. I'm in a situation now, however, where the council is forcing me to move. They're going to put me on universal credit, which means that I will have to wait before I get any help with rent. I'm not sure how I'm going to make out with that. At 72, no one is going to employ me. So I think my options as far as increasing my income are just not there.
If I'm lucky, I'll have a shift a week. That's £78. Take out travel and food, it don't work. Live off that.
When people ask me, what do you do? And the easiest answer is, what do I do? I work as a nanny. Myself and my son have just ended up hiring bouncy castles out. I'm also a full-time student, and it doesn't seem to matter how hard I try. I never really feel like I'm getting anywhere.
Poverty is frustrating. It seems as if you're fighting against a tide, and the tide is always running against you.
I'm being dragged so far, I'm surprised I'm not underwater already. It's draining, it's physically draining. There are days I struggle to get out of bed even.
Having poor mental health traps you into cycles of poverty that you feel that you have no way out of.
Cuts to certain services has definitely had an impact in how people are supported.
I believe that public services are there to keep you safe, protected, and provide your basic needs. You know, you pay into it in your good times so that should you fall on hard times, that you can actually take back from that.
I know that economically it doesn't have to be this way. And I feel very much that there's much more as a society that we could be doing to change things.
It's never right to be living in poverty. It's never right, and especially for children.
It's inhuman. It's not right.
I think we all need to be a lot more compassionate. The world doesn't work without compassion.
Yeah, I feel like people kind of judge. you know, and say that you're not responsible, that you haven't got a clue.
I have a few different health conditions and disabilities, so as soon as I open my eyes in the morning, I have to assess how much pain I'm in. I'm sure that there's big sections of the population that just think we need to try harder to get out of poverty. Like, I wish it was that simple, so much. I really do. I'm smiling while I'm saying it, but like, I am crying inside. I wish it was that simple.
I want my son to be an astronaut, but is he able to do that? He needs to be emotionally, physically capable. If he's getting enough food, his mental health is healthy.
I always live in hope. I've lived in hope for as long as I can remember.
And I think you have to hang on to the hope that you can find.
I will step back sometimes and go, I've had enough, I'm not doing any more. And then I have to think, no, you can't stop. You've got to keep going.
I would say that for anybody living in poverty, I don't think there's any shame in that at all. There's quite a lot of strength and quite a lot of bravery to continue pushing through a situation like that.
Thanks, Lauren. And if we can, Freddie, if we can just put the slides up, if that's okay. So I mean, I think, you know, it's the shame, feeling judged. It's no wonder, is it, that being in poverty is really bad for our health in so many ways. So we just want to say something, just first of all, just in sort of going through the highlights, really, just a little about the scale of this. So if we can move on to the next slide, if that's okay, before I hand over to Freddie. I mean, the scale of this is absolutely unprecedented. I've done a little bit of a chart here. So the first bar, the small bar, is the number of deaths, the average number of excess deaths we get in a winter in this country. The second bar is the deaths we had throughout in the whole of the country throughout the COVID pandemic. So, and the chart to the far right is how many deaths we're predicting will happen this winter, just this winter, due to cold homes. So in terms of just the scale of this, and think about the resources and the effort and the energy that went into the COVID response, and the predictions from, and these aren't just my predictions, of Health Equity, Sir Michael Marmot's team that are making these predictions. Now, there may be some mitigations due to the emergency budget that we'll hear, but whether those will be able to reduce that significantly is questionable. I'm going to hand over to Freddie now. It's going to really just bring you in a couple of minutes just through some of the highlights that we wanted to make.
Thank you very much, Deb. And hearing the human impact and the scale of the cost of living crisis and poverty, it really kind of, I think, sets the tone of how big a challenge we are facing. And it does link to lots of conversation that I've obviously only joined this meeting slightly late, but I could already hear lots of reference to this work, and obviously it links really clearly to the strategy that Esther kind of discussed. So while there's many causes of poverty that are out with our direct influence or control, I think in this paper we wanted to highlight on some of the things that are within our sphere of influence across the partnership, and of some of the great opportunities we potentially have in addressing this. So we've tried to develop a little bit of a, if I can forward the slides, which doesn't seem to be working. There we go. We wanted to think a bit about structure, about how we could frame some of the things that we can do. And I think just as a quick note is to kind of mention, obviously, that while we are focusing on the partnership role, there's obviously the partnership is made out of a range of organizations, and all of these organizations have a role of addressing poverty within their own rights and within their organizations. And we've made some recommendations for the ICB as an organization, but that obviously would apply to all other organizations within the partnership as well. The other thing to mention is obviously that there's a key strength in us being a partnership, and there's obviously a lot of work already existing that addresses poverty and the drivers of poverty, and some of that work through kind of WICA, the local authorities, third sector. There's some work that obviously was referenced just now from the race and ethnicity review around employability and employment. So a lot of work is already going on. So there is something pretty much in what we're trying to present already in existence. It's not about reinventing the wheel, but really building and scaling up, just given the scale of the challenge that Deborah's outlined for us. So the way we've kind of developed this framework is thinking about the approaches that the King's Fund has laid out about approaches that the NHS can use to address poverty, and they're the approaches of advocacy, awareness and action, as you can see outlined around the circle here. And action, I guess, also kind of divides into actions to mitigate the consequences of poverty on health, on the individual, but also in the healthcare system, but also actually addressing the drivers of poverty, which are increasing income from employability, from benefits and welfare advice in kind, as well as reducing the cost of living. The other thing for us to think about as organizations, but also as a partnership of organizations, is our role as anchor partnership, I guess, or anchor organization in our own rights and as a network of anchors, and in particular around our roles of procurer of services, deliverer of services, and employer of services. And that's how we've tried to structure some of these approaches we can take. And all of them obviously contribute to those 4 aims about mitigating the health impacts of poverty, contributing to reducing poverty in West Yorkshire, supporting resilience across the system, as well as kind of tackling the stigma of poverty and making sure that people with experience of poverty are included in all the decision making, are co-designed to what we are doing, which is obviously in line with what the partnership is trying to do across everything it does. And I've kind of just outlined here a couple of examples and for all of these ideas around the kind of cartwheel here of ideas, there's probably, for everyone that's mentioned there, there's 3 other ones that could be there. And I just wanted to kind of just highlight a couple of things. If you think about our role as a deliverer of services, there's obviously work we can do around financial inclusion pathways, which have been tried really effectively in other areas. Can link into existing service contacts, maximize those service contacts, and refer into welfare capacity across the system. So it's really not just one organization doing this, but really working across organizational boundaries and as a system. And another area of work where we've evidenced this is affordable warmth work that we've done, where affordable warmth interventions are taking place across the partnership. But how can we use intelligence across the system of identifying people most vulnerable to living in cold homes because of underlying health conditions, or most at risk of finding themselves in fuel poverty this winter, with the consequence on their health, mental health and well-being, and really kind of target the interventions to those most at risk. So again, the added value of working as a system. The other thing that I kind of just want to highlight is around our role of procurement and the social benefit clauses we can use. And again, there's obviously a lot of work going on around that, but how can we make sure using inclusive employment and generating employment opportunities for our local populations? And I think as a role of an employer, I think is a really key one for us to focus on, because we know that the well-being and welfare of our staff is crucial in us being able to deliver health and care services. And we sadly do know that across health and care sector, up to 13% of the population in 2019 were in work poverty. And obviously with the prediction of the rising cost of living crisis, that's only going to go up. So there's real things we can do around increasing the living wage. So there's going to be a real living wage uplift in September brought forward because of this crisis. And there's something we can look at, how can we adapt that and move people onto the real living wage as soon as possible across the partnership. But also looking at work we can do to reduce the cost of work and the kind of expenditure around childcare, but also other things that were already mentioned in the previous discussion about flexible working and allowing people who are at higher risk of being in poverty to be able to get into employment and career progress. So sorry, this has been really quick, and I think that's just with the intention that we have a lot of discussion afterwards. So I hope this has given some ideas that there's a lot we can do as a partnership. And we just wanted to kind of really propose the next step about how we make sure that the response we take to this is how we learn from COVID. So our response to COVID, we have shown how effective we can be when we work together across a partnership, across the organizational boundaries with a common aim. And I think that there's something, given the scale that Debs has outlined, this is probably as pressing, if not more pressing, than COVID has been. And I think the other recognition is to consider that the cost of living crisis and the climate crisis are just so interlinked that it'll be very difficult to address them in separation. So our recommendation is that we set up a joint response that considers both of those elements. In order kind of to facilitate that, we suggest that maybe an anti-poverty task and finish group to help develop and the strategic approach of the West Yorkshire Partnership, building on all of the expertise that's already in the system, and the local authority leads from WICA, from the third sector, people with lived experience, to make sure we draw and build on what's already in existence. We also kind of said obviously about recognizing the urgency and ensuring that we have a systemic lead for leadership around this remit. And ensuring we've got a very clear action plan that we can look at the short-term, medium and long-term actions and their impact, because what is key is while people are experiencing the health impacts of poverty already, and it's obviously predicted to sadly get a lot worse in the medium term, we need to look at long-term solutions as well. We need to kind of break the cycle of poverty and not just try to put sticking plasters on this and alleviate cost of living crisis, but really think about how can we address poverty in the long run, because otherwise we will never get on top of it. And obviously how people have described this tide, I think we'll be facing something very similar on an organizational level as well. And again, the key point as well that obviously I know everyone in the partnership agrees on anyways about the inclusion and co-design with experts by experience and people from and including the VCSE sector in all of these discussions to make sure it's a joined up approach. So the ask to the membership is just so that we consider making technical. Yep, sorry.
Freddie, sorry. If you leave that slide up, I think that's really helpful. I'm just conscious we've got 10 minutes left and you've got some hours. No, thank you so much to you and Debs for a comprehensive presentation. And if we can send these slides afterwards, I think this is a good summary to then for leaders here to then take into their organisations as well. So thank you very much. And I think we made a commitment right at the beginning of the meeting today, starting with our Chief Exec's report on making tackling poverty a priority. So I think what we can do, Freddie and Debs, is then share with you the commitments that have come out of this meeting today that complement a lot of things that you're supporting and recommending today. I'm conscious of time and questions. Councillor Scullen, you wanted to ask about suicide prevention. So if we hand to you and then to Councillor Hinchcliffe. Thank you for the presentation.
Thank you very much for the presentation. And I think there's a lot of other similar things out there with different perspectives, different lens on the issues. The Leeds Truth Commission, for example, which I think has had very moving testimony from people. But on your wheel of things, and it's partly covered by dealing with mental health consequences and the shame of poverty and so on. But I'm particularly interested in us sharing best practice across organisations, different types of organisations, about suicide prevention, particularly amongst men, particularly amongst young men, in terms of people finding themselves in poverty who didn't expect to find themselves unable to cope with. Plea for a real sharing of good practice and organisational sensitivity to those issues. Thank you.
Thank you. I'm in the interest of time, I'm going to reply on behalf of colleagues. We had a great presentation on our suicide prevention strategy at our March meeting, and I think Councillor Scullen, what we need to do is revisit it and then come back on sharing best practice linked to this as well. So we'll keep making notes of what we need to do. Thank you. Councillor Hinchcliffe and then Liz Meir.
Thanks. Yeah, so really welcome the comments about anchor organisations. Each one of us is an anchor organisation. It's easy to advertise in advance what your procurement's going to be for the next year. We have new hospital buildings programmes. That's a massive opportunity to create employment. Anything we spend, any of us, we need to think about the local economic benefit, and that should be hardwired into each of our organisations. It's easier said than done, I know, but we all need to have that intention of a programme to deliver that. You're right, we've all got anti-poverty groups that we're all working through this in Bradford at the moment. I'm sure other local authority leaders are as well. So gathering those people together, I think, will be a first step. That's fine. Sustaining ourselves as organisations so we can support people, I think, is also important. Chat with Rob about that the other day, just to make sure that we're there and we're not distracted. We're always on the front line supporting people in most need. I think just the other thing I mentioned is welfare advice. We as a council spent £2 million a year on welfare advice. Pre-pandemic, GP practices were also providing welfare advice in their surgeries. That was obviously cut now. A lot of it's online, but I think there's a role for more welfare advice given what's coming around the corner. And I'm not sure, there was already 250,000, 300,000 in Bradford. It may well have been more when you sort of accumulate that across West Yorkshire. Should we be looking at that as well? So we can just put that in to supplement what's already there. We fund that through our VCS.
Great. between already Councillor Scullin and Councillor Hinchcliffe, we've got some actions in to do this and bringing people together. Thank you for those. Liz and then Councillor Kendrick.
Thanks, Kathy. Thanks for such a comprehensive report. And the one thing that I was looking at was this anchor institutions and procurement. And one of the things that we already have targets for in the NHS is paying small businesses quickly. We have lots of residents employed in small businesses. We often don't meet that target, and those businesses are at a real risk of going under. They're not, the energy price cap doesn't apply to them. People will be wanting to go into workplaces maybe to keep warm, so they're going to be under real pressure. So it was just that doesn't seem to be reflected, and it's probably, I'm not saying it's simple, but it's something that we could have a focus on that might keep firms in business and people employed and healthy and money in the pocket.
Great, thank you, Liz. And I think there's a theme coming up from both you and Councillor Hinchcliffe on anchor organisations, procurement, supply chains. I know there's a number of people, including Mike Woodhead here, who has worked on different ways. I've also made some inquiries nationally as well as about how we can perhaps have more flexibility to make sure we're bringing more social value and spending local money in local places for local people. So I've got a suggestion on an action as well. So let's keep going on people's thoughts and ideas because we've got a long list. And Sarah Monroe, I see you've got your hand up. Could you come back on Councillor Scullin's points on mental health when we get to you? That would be really helpful. So next is Councillor Kendrick and then Councillor Arif.
Thank you, Chair. I mean, I love your report. I particularly paid attention on the wheel to accessing care, not worsening poverty, because I think all of us, in whatever work we do, need to be thinking about that the whole time. And embedded welfare services, as I spent my whole working life as a welfare rights worker, so this is really important to me. I do believe that all frontline workers should have a curiosity about what life is about, regardless of what they've come about, and that applies to managers of services for their own staff. And I do think there's a knowledge base needed for frontline practitioners about what's on offer. And I don't mean people having to do extra things. I think we need to set up systems where there can be positive referrals for people who need help. In the same way that social prescribing has been so successful, and I think we could do that. I sat and jotted down while when we started, and I came up with 11 different actions and activities within our council area, and I bet people don't know. And I think the other bit is about the potential for us considering additional investment in some of those. A lot of voluntary and community organisations provide some fantastic things like uniform exchange, the baby bank and so on, the bread and butter thing, and we need to really be making sure those continue on to support our people in the community. All right.
Great. Thank you, Viv. So I think what we'll do is put together all the actions and suggested proposals, as well as let's learn from each other. We've had that theme today as well, haven't we? What's good practice here that you might want to steal for your place or your services? And let's not lose any of this. And I suggest to my colleagues in our West Yorkshire team, let's do this really quickly. Minutes of this meeting can wait. Let's just turn this section around quite quickly. OK, so Councillor Arif next and then Sarah.
Thank you there. Councillor Kendrick has taken my point there about signposting. So, for example, just to extend on that point, in parts of Leeds, we've got something called selective licensing, and we know a lot of young children who live in damp houses with respiratory problems. It'd be really great if the GPs could then know about that area and refer that back. It means the council can go through the doorstep and have those conversations with the landlord. So I think that knowledge of local staff knowing what's available in that area and how they can work closely with the councils, I think that's really important. The other thing I've had from, and there's a campaign I'm working on this, is our pensioners, our elderly residents who are not able to get on the bus before 9:30 a.m. and not able to get to the early appointments and the disadvantage that has. Perhaps a conversation with the mayor in terms of how we can ease that burden. Again, it's going back to the financial side of things. So those are the 2 points I wanted to make. Thank you.
Thank you very much, Salma. And yeah, I think there's probably a to-do list for a number of us, and there's some things that Rob and I can then take to Combined Authority and the Metro Mayor as well. Thank you. Sarah, then Khalid.
Yeah, thank you, Kathy. It's just in terms of the concern about the mental health impact, absolutely. And I think depending on whether this goes into a longer term recession, which is the risk at the moment, then not only will we see the additional demand because of the last couple of years, but that increased demand over the next couple of years. The specific point I wanted to raise really is, because this is quite an emotive subject, there is a hidden cohort that existed before the current challenges around cost of living that don't have structural support, are in temporary housing, move from house to house, probably at risk now from landlords putting prices up. Kids not necessarily in school because parents can't afford to send them to school. So they won't access services in the same way to say we need help. And you know, this cohort of people have been around for generations. So I think it's really important that in trying to address this bigger challenge for a larger group of people, there's a danger that we don't provide the additional support and outreach to that cohort that are incredibly vulnerable and again from very just really a plea that we have that in our line of sight. And again, it's very much a local authority led response. But I'm keen because they will be the first to have the worst outcomes and effect from the wider changes in terms of cost of living.
Thank you, Sarah, for that reminder, of course. Thank you. Khalid, then Faluke, then James, and then Rob, I wanted to come to you. So Khalid, then Faluke.
Thanks, Kathy. I have to keep my camera off because my laptop's battery is really running low. So I did put it in chat, and when Liz mentioned about small businesses, I relate to it. A lot of my colleagues are raising on social media concerns about rising energy costs from October onward. There was a quote there, which was from a small pub whose new quote from October onward is coming to £72,000 a year for energy bills. And I'm just wondering, that these, we as primary care, these practices are small businesses as well. And we are really worried about having to, pay that cost. And that means that we may not be able to afford, a nurse and a half or something. And then that's something which is really worrying, where we know the poverty is directly related to illness and illness behavior. The demand is expected to go high, and if we are not staffing ourselves properly, we will be really struggling. So we need to think of ways how we can support practices in keeping on delivering on the service. Primary care is at the heart of delivering the healthcare, and if they are not able to do that, then our population will be worse off, to be honest with you. And then that's something which we need to be mindful of. Thank you.
Thank you, Khalid. We've got recommendations in this report to come to the Integrated Care Board, which we'll take forward. And there's also Rob's suggestion, and which we'll take forward as well, of looking in focus at primary care, so we can bring that in as well. Thank you for that. Faluke, then James, then Rob. I hope you can spare us another 5 minutes or so as we finish up in the meeting. So Faluke, next.
Yeah, thank you. It's just building on that last point. There's something about making sure that we also don't forget our own colleagues, those who are in organisations that are lowest paid, who will probably be, some of them in this category, or will have relatives and friends in this category. So as much as we socialise it and try and remove the stigma for our own colleagues, and more that they can then socialise it within the communities that they live in, because we are all still all part of the community. And I think there's just something about making sure that we can immerse ourselves. So that point that was made earlier about every healthcare worker knowing what's available, actually, if we can make that really prominent, then that will enable that to happen.
Great, thank you, Faluke. And there's some real killer stats in the document, isn't there, about particularly 12% of health and care workers living in work poverty. So it's something I hope that you as leaders can take forward, as well as through place committees and provider collaboratives. Thank you for that. James, Thomas, and then Rob, and then we will finish up the meeting. Thank you.
Thanks, Chair, and thanks, Debs and Freddie, for the paper. And I suppose building on some of the points both Councillor Kendrick has mentioned and also Sarah, in terms of, I suppose, how do we be more proactive in this? And I was just thinking in terms of we know some people are reluctant to come forward. Sarah has talked about kind of that kind of people, these are most vulnerable people, the stigma there in terms of coming forward for help, and rather than wait until the extremists. And I know that can be extreme. How can we be more proactive? So I'm thinking about kind of population health management tools that we've got using our core 20+5 and things that we've already got. Actually, we could kind of piggyback on, look at to try and focus on those people to be more proactive, and we can do that in a more short term as well as medium term approach there. So I'm thinking this in terms of kind of the proactivity and the stuff that we're already doing that we might be able to kind of piggyback on, look at using those health checks to be able to signpost to places, and recognizing that our most deprived people probably got the worst health, and therefore going to come up on these population health tools to be able to kind of focus down on, be a bit more proactive. Thank you, Chair.
Thanks, James. And I think it is initially thinking about what existing forums and work we have in place where we can step this up, be proactive, or slightly think differently. And Kim, we're running out of time, but hopefully we can then work with HBox and a number of our colleagues, if not all, in voluntary community and social enterprise sector and faith sector as well. One thing I wanted to suggest for council leaders, health and wellbeing board chairs, and for provider chairs, we used to meet on a last Friday of the month to talk about setting up the integrated care board and what this NHS West Yorkshire thing would be. And I wonder whether we take that time back together to meet to take this issue on together. So I'll email separately, and that might be something we can do as leaders, which complements Freddie and Debs, what you're talking about, but also aims to complement the existing work that's taking place that James has talked about in brief there. So Rob, what are your thoughts here on the suggestions as well as the proposal?
Well, just two thoughts really. So first, just to support all of the resources that Karen and Gary and others have put in the chat about mental health, wellbeing and suicide prevention. Everyone's been making comments over the last 2 years about the impact of COVID on mental health and suicide. There's no evidence that COVID increases suicide rates, but there's lots of evidence internationally that suicides increase during recessions and economic downturn. So this is a real and present risk for us, and it's right to focus on it. I think the second comment I would have is that clearly this is something where there's a lot of work going on and a lot of ambition and some boldness required. I saw Tim Riley's comment in the chat about making sure that we're doing the right work at the right level and not duplicating, and I think it's right. So I'm aware that West Yorkshire Combined Authority are taking a paper on this topic and what they could do, and we've also got a regional directors of public health meeting where they're looking at what the region could do. If we're not careful, we'll have too much duplication and not have coordination. So in taking this forward, I think I really like the suggestion that we take this in the way that we did the COVID work, where we said, look, this is a real present issue for people right now. So what are we going to do? What's already been done in places? What do we need to do at West Yorkshire level? And I was really taken by Councillor Kendrick's point about curiosity. Nobody's got this cracked, and we should all be curious about what others are doing and then nick it and do it better. That's always been my kind of ethos. So let's apply it to this. But I think getting a West Yorkshire approach built for employer and amplifies or fills in gaps rather than duplicating will be important, and agreeing that with the combined authority is essential, I think.
Thank you very much, and I feel that everyone's committed to mobilising. It's just mobilising us in the right direction. So respectfully use us in the right way, particularly the leadership that we have here. Okay, thank you very much for that discussion, and colleagues who are helping with the administration and governance of this meeting. If we can, as I've said, write up the notes and the actions around this particular agenda item. And that would be very helpful, and then we can work on the minutes at a later date. Thank you for staying on for an extra few minutes. I appreciate that. I've enjoyed the meeting today. It's a shame Tim Swift has missed this meeting today, but we can send him the recording while he's recovering. And thank you for your contributions, ideas, passion and commitment to our partnership. We're really, really grateful to you. If you need any help from Rob and I, please let us know. Please continue to exchange practice with each other and support each other going through this winter in the new ways of working as well. So again, thank you for your time. Our next meeting's on the 6th of December, but I'm sure we'll see each other very shortly, and I'll be in touch with provider chairs and council leaders very shortly as well. So again, thank you for your time. I'm going to stay on for a few minutes if anyone's got any questions, but again, take care and catch up soon. Thank you.
Thank you.